is um, a surgical procedure which aims to reroute urine from the normal pathway that it's supposed to have to an alternative route. And it may either be, it may be classified in several ways, either as a temporary or a permanent way, or it can either be on the basis of the location, if it's an orthotopic diversion or a heterotopic diversion. And heterotopic diversions are also subclassified again into either if they're continent or not. And there are several means of urinary diversion. As you can see, we have ureterocutaneostomy, which will be one of our focus today. Then we have ileoconduit, which is also commonly performed and was established in 1911, and we're also going to look at it today. Then we also have ureterocolonic diversion, and then we have high diversions to the transverse colon in cases of pelvic radiation. And we have the pouches, the continent mechanisms and the pouches, which we are going to look at. So, yeah, so what's the ideal method for urinary diversion? The ideal method for urinary diversion must be a method that is non-refluxing. It creates a low pressure system. It must be a method that is mimicking the bladder compliance system. And so it must be able to be continent, and it must be able to store a functional amount of urine, at least 500 mils, and must be non-absorptive, must be able to reproduce the functional normal urinary tract, and even preserve normal renal function, and even maintain an undisturbed body image. And this is very important, as you shall see, even in ileoconduits. So there are several indications for urinary diversion. Most commonly, the one most relevant to us as urologists is the oncological indication, especially that is the first one, and that is bladder cancer, especially T2 disease and above. How do you select the correct type of urinary diversion for a patient? There are several factors to look at. The age of the patient is important, the sex is important. If there are any comorbidities, for example, if the patient has inflammatory bowel disease, then maybe you don't want to use the intestinal segment, you just want to do a conduit. Oncologic extent of the disease may affect your choice of the diversion. Renal and hepatic functional status, bowel condition will determine if you're going to use bowel or not, and even patient's preferences, and even the expertise of the surgeon. Because some of these have a very high learning curve. And they have, when you use intestinal segments, there are different, right from the stomach down, there are different indications for their use, from the gastric to the jejunum, to the ileum, to the colon, and even to the transverse colon, as we have seen. So just something little about ureterocutaneostomy is when you divert the urine from the ureters and you divert them out to the skin. And there are four main ways of doing it. You can just pull out the individual ureters independently, or like in this case, or it can be a double, you can pull them and they're separated on the skin, and at the same time you can actually divert in a double-barreled fashion, or you can join them together and then they come out as one on the skin. So these are just different ways, and ureterocutaneostomy is not commonly performed, but it has a role, especially in our elderly patients, for different reasons which have been listed. The main method that most surgeons perform is the ileoconduit. And we mainly do this, especially after we do our radical cystectomy, then followed by the ileoconduit. It is a method that was discovered in 1911. It has a steep learning curve, but most surgeons are comfortable with it because they are able to, it has a lot of advantages. According to a surgeon who regularly practices, it's a relatively simple surgery. And it also requires, it is said that it requires less surgical time. And there's actually no need for even occasional catheterization when you use this method. So what you do is it usually is you take a segment of bowel about 20 centimeters and about 20 centimeters long, and it should be about 20 centimeters proximal to the ileocecal valve. And you maintain its mesentery for its blood supply. You close one end, and then you now choose the technique of the ureteral anastomosis to the bowel, either a Brica or a Wallace. I've mentioned the advantages, but it has several complications too, mainly metabolic challenges or even mechanical challenges. Now, quickly to continent catheterizing pouches, this is another form other than ureterocutaneostomy, ileoconduits. We also are very particular about continent catheterizing pouches, especially mains 2 pouch, which is a friendly and it's another easier option for the general surgeons. And there are several, but I'll only concentrate on the mains 2 pouch given the time and the relevance that we have here. So it is also called a sigma rectum pouch, and mainly what you do is that you open up the bowel in a longitudinal fashion, but you end up closing it in a transverse fashion, as you've seen. So what you do is that you create a reservoir in the rectosigmoid area, which has which mimics the bladder compliance, so that it can fill with low pressure, but are able to achieve good volumes. So this is what basically mains 2 does. And careful patient selection for mains 2 is important because you have to choose patients who will be able to tolerate it. It is a very good method, especially to our Muslim community, because they mostly do not like ileoconduits because of the leakage of urine around there. And also when they go to pray in the mosque and they are bending down, it becomes a bit messy. So this is a preferable method since it's a continent mechanism than the ileoconduit. So a little bit about ureterocutaneostomy. I found some interesting literature, which it was a study about a meta-analysis of about 70 studies, which was done by a gentleman called Fronla et al. And he looked at a comparison between 3 main techniques: the ureterocutaneostomy, ileo-diversion, and actually continent diversion. And he actually proposed that this method...
You have less than 2 minutes.
Okay. That this method should actually be considered in the elderly population, especially who have in the elderly oncologic populations. And he looked at the data from the preoperative time, the operative time, and even the postoperative time. And what he ended up finding out was that it had lesser complications and it appeared to be better. And the other study that was also quite interesting in urinary diversion was by Madasbacha et al. It is the largest study that was done on ileoconduits, which followed up 412 people over a period of 98 months. And it found out that after 15 years, almost all ileoconduits fail. Then the last one we would have talked about is the neobladder, where you actually create a new bladder because of reasons of which you cannot use the bladder, either oncologic reasons and so on and so forth. It has several advantages, and it also has a few disadvantages, especially surgical time and need for a longer bowel segment. So just a quick one on locally what we have done is that there's a study by Dr. Mugallo from from Moi University. It was a case report of 3 series, of which they looked at, I think, 3 patients. One who had a neurogenic bladder dysfunction due to myelomeningocele. The other one had a spinal cord injury, and the other one had a PFUD. And they actually documented very interesting findings that they did a Mitrofanov appendicovesicostomy in the third patient. And in the first case of the study, they actually were able to construct a Mitrofanov channel using the Young-Monty technique. So I felt this was a very interesting study, given that it's our local data that was published. So in conclusion, the main issues that we need to look at when we are choosing appropriate options for urinary diversion are diverse. There are oncologic factors to be considered, there are general health factors to be considered, there are technical health factors to be considered, and health-related quality of life factors, and they are listed above. So you have to customize each case according to the patient selection, the appropriate surgical expertise, the age of the patient, the condition, and even the disease, if there's disease in the bowel, and so on and so forth. Otherwise, thank you very much, and thank you for listening.
Thank you very much. Now, our next presenter is Dr. Otele, who is a consultant urologist and the chief medical specialist at the Kenyatta National Hospital. He's going to take us through the pelvic fractures, associated posterior urethral stenosis, a Kenyan experience. Welcome, Doctor.
Thank you, Bernard. Thank you, Co-Chair Sam. Thank you, the organizing committee for CALS in Kitui. We don't take for granted the effort that you make to organize something of such a magnitude. Today, I'm here to address the complication of stenosis that occurs consequent to pelvic fracture urethral injury, abbreviated as PFUI, but our forefathers in urology used to abbreviate it as PFUDD, the likes of Turner Warwick, but this was a misnomer. It's not PFUDD because it's just a urethral injury most of the time without displacement or destruction defect. In the interest of time, I'll not cover many slides. I'll just go to the study straight away, but a brief introduction. I have no disclosures to make. Now, the area that we are going to be looking at is the area of posterior urethra, which is about 4 centimeters. This is a very sensitive and privileged part of the urination system because the sphincter is not far from the area where we operate. And number 2, the nerves responsible for erection at the base of the prostate are not far from there. And thirdly, the ducts for ejaculation, for emitting semen, again, are not far from there. And this affliction is an affliction of a young person. So if the management, we don't get it right, then the patient more or less lives with this condition. So it becomes a quality of life issue. That area of the membranous urethra, the one I'm talking about, is the most unprotected part of the urethra. It takes about 1.5 centimeters, not protected by the prostate, and either not protected by the corpus spongiosum, which is just limiting a little distance away. And this injury is a bulbomembranous, contrary to earlier belief of being prostatomembranous. It's not prostatomembranous unless it's occurring in a pediatric subject. Algorithm in the management. There's an algorithm there. When you get a patient with pelvic fracture urethral injury, the first thing is to resuscitate and determine the degree of hemodynamic stability. For unstable patient, there's no room to do any fancy thing. Resuscitate, 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 and then put up a suprapubic catheter at the tail end of this resuscitation. So make sure the patient is stable. But for that is an unstable patient, resuscitation, put an SPC, and continue some other line of management. No room for fancy things. But if it's a patient who is unstable, who is stable rather, then there are 2 ways you can do it. You can do endoscopic alignment. Open alignment is contraindicated, or you can do an SPC. SPC or endoscopic catheterization. Then from there, after catheter has been in situ for about 4 to 6 weeks, you remove to see if the patient can void. If he's unable to void, it means he has formed a stricture. You leave that stricture to rest for about 3 to 6 months. Then you do delayed management, which is urethroplasty by EPA. And because we are doing bulbomembranous anastomosis, so the EPA is a bulbomembranous anastomosis. So we performed a study at KNH. I'll go straight away to the study. Yeah, so this was a prospective cohort study covering that period indicated at KNH. Sorry. Aims to compare the efficacy of SPC, suprapubic catheterization, and endoscopic management in pelvic fracture urethral injury, and to evaluate the morbidity that is arising and the treatment efficacy of that morbidity that arises from pelvic fracture urethral injury. Suffice to say that this study was peer-reviewed, the proposal, and allowed at that time. The inclusion criteria was stable patients, like I've said, 18 to 80 years old, with normal erectile function. The ones who are unstable or didn't give consent were not included. And there were two primary outcome measures. Primary one was urethral patency. The second one were complications such as ED, things like UTI, fistula formation, and incontinence. The method was that patients with PFUI were selected alternately for SPC or endoscopic management. So we selected 40-40 for each arm, but there were 15 in favor of SPC due to unavailability of theater, because endoscopic realignment is theater-based almost exclusively. Now, the ones who failed the two procedures were subjected to delayed urethroplasty after a period of 3 to 6 weeks. That is a procedure of endoscopic management. You need two telescopes, one in the suprapubic tract, another one in the urethral tract. So you meet somewhere in between. You align the urethra, or if it's not deviated, then you just pass the scope all the way into the bladder and use the channel, the catheterization chamber, to pass the urethral catheter, pure silicone, which is going to be there for a period of 4 to 6 weeks. Now, the ones that failed are done excision and primary anastomosis, the one I'm referring to as bulbomembranous anastomosis. This is a difficult operation, and it has 4 cardinal steps. Bulbar separation, which gives you 2 centimeters, followed by excision of the stenotic part. You can also do crural separation, and if that doesn't give you sufficient length for anastomosis, you can go to a more elaborate step. There are 2 parts of this elaborate extension. One is inferior pubectomy, the other one is rerouting. Rerouting is frowned upon because it is associated with those severe complications. If you are not able to achieve sufficient anastomosis, which is tension-free, it's advisable that at that point you proceed to abdominal perineal approach. Let's look at the results. Again, you must remove fibrous tissue. 2 main causes of failure is failure to remove fibrous tissue sufficiently and anastomosing under tension. So you can see that fibrous tissue has been removed to a large extent, and the piece is ready for anastomosis. And that is a finished product. Then you close with a drain, antibiotics for as long as the catheter is in situ. Okay, these are the results. As you can see, these are young patients. These are young patients from 18 to about 33 years. Those are the majority, 3/4, 18 to 33 years. This is in keeping with studies elsewhere, like Corritim in a study reported in British Journal of Urology. Most of the patients were young, and in a meta-analysis done earlier on, they were ranging between 22 years and 38 years. So this is a very young segment of the population. If you look at the results of primary treatment, I said there are 2 arms of treatment. Primary just was catheters, endoscopically or suprapubic. So in the primary treatment, 4 patients failed out of 55 patients. 4 patients failed. So giving a percentage success rate of about 5.5%. The rest of them developed a urethral stricture. After SPC, 77.5 developed urethral stricture. When we went to secondary arm of treatment where we are doing excision primary anastomosis, or if that was not possible, we are using a graft, or if that was not possible because of length of stricture, we are using a stage operation. The results were as indicated there. When you are using SPC, the ones who underwent the route of SPC, the outcome was 65%. The ones who had done endoscopic reduction earlier on and they failed, the results were about 55.5%. That slide is crowded, but what I wanted you to note is that in the middle part of the slide, the people, the etiology of the injury, most of them are motorcyclists, and some of these injuries are secondary to fall in a ditch, fall in a pit latrine, or fall in some empty space somewhere. Compression is also a cause of this, or even those people who travel as pedestrians, and the common denominator is that they are all young patients. So I'm going to summarize. As you can see, the cyclists are 32%. The ones who are like secondary to fall or pedestrians also occupy a larger proportion. The complications, like I said, is urethral stenosis, erectile dysfunction, and incontinence. So in conclusion, pelvic fracture urethral injury is common, and it affects a young segment of the population. It is a public health issue, it's predictable, it's also preventable. The management of related sequelae can lead to morbidity, which is lifelong. So this is a quality of life issue. And endoscopic alignment in carefully selected cases is beneficial. If you looked at the p-value corresponding to those ones who have done endoscopic alignment, the p-value is significant if you compare to those who have just done pure SPC. So in conclusion, prompt and appropriate management is imperative to avoid long-term sequelae, because this would end up being a lifelong process. Now, those are the gurus in urology. The middle one has departed. He died in September last year. I know Professor Mungai must be knowing him. That is a famous Tana Warwick. And those are his students. One is Kulkarni on the left, and on the right is Justin Chief from University of Melbourne. Thank you.
Thank you very much. The audience, just note your questions. At the end of the sessions is when we're going to ask the presenters those questions.
Now, Dr. Oluoch is our next presenter. He'll be taking us through venous patch for severe Peyronie's plaque. And we ask, we've jumped presentation by Dr. Langole, which will come towards the end of the session, right before Professor Mutambirwa and right after Dr. Sheikh. So the floor is yours, Dr. Oluoch.
My name is Dr. Nyango Oluoch, a radiology resident at the University of Nairobi, level 5. As Dr. Kagiri has rightfully said, I'm going to present on the use of venous patch in severe Peyronie's disease. The presentation is coming up shortly. So Peyronie's disease is an acquired penile abnormality that is usually characterized by fibrosis of tunica albuginea. Most of the times it is accompanied by pain, deformity, erectile dysfunction, and distress. The exact pathogenesis is not exactly known, but is highly hypothesized that is a wound healing disorder in genetically susceptible individuals, particularly following multiple trauma, microtraumas during sexual intercourse. The prevalence of this disease is wide-ranging, and it's quoted in literature to be between 0.3 to 20%, and it peaks in the early 50s of age. The severity of this disease is by Kelemi system, where less than 30% of the curvature is a mild disease or grade 1, between 30 to 60% is a moderate disease or grade 2, and what we are going to look at today is grade 3, which Kalemi defines at more than 60 degrees. And in only 13.5% do we get severe Peyronie's disease. If we go shortly to relevant anatomy, the tunica albuginea is in 2 layers and usually is composed of type 1 collagen and elastin. Of note is that ventrally, the outer longitudinal layer is missing, and that contributes to ease of buckling of that layer of the tunica albuginea dorsally. Anatomically, what contributes significantly to this inflammation that is uncontrolled is the fact that the arteries around the tunica albuginea are usually under a cuff of loose areolar tissue. They are protected, while the veins are not. They are in direct contact with the tunica albuginea. Whenever there is trauma, the resulting inflammation impinges on these veins. So there is inflammatory processes going on. The leukocytes, the macrophages bring in interleukins, fibroblast form, but that inflammatory process cannot be washed away because the veins have been impinged. When we go to evaluation, it starts like any other disease with history, physical exam, and some other imaging. So in the history, we'll be interested in the pain, the onset of that pain, the duration of the pain, any curvatures, and any assessment of rigidity from the patient's perspective. On the physical exams, we'll be interested in palpability of the plague, the direction of that curvature. If the patient has done any photographs at home, we can also assess that and help us in diagnosis. The definitive evaluation comes in Doppler ultrasound after injection of vasoactive intravenous prostaglandins. The Doppler ultrasound is of paramount importance because it's only through that you can objectively define the curvature and the hinge deformities and the irregularities in the girth of the penis. It is also important to know the vascularity of that penis so that you will know whether erection will be sustained even after you've done your surgery. It can also help you in diagnosing the fibrosis of the corporal bodies and the calcification. What is very important in this disease is that you discuss with the patient the expectations. The aim of surgery is to obtain a functionally straight penis that can engage in sexual intercourse, which is defined by a curvature of less than 20 degrees. You also need to inform the patient that with the grafting, he runs a risk of diminished rigidity and decreased sexual sensation. But that is usually a transient thing. In most of patients, it will clear in 6 months. So the surgery that is involved in severe Peyronie's disease, and we are going to talk about it today, is a plague incision or excision. You're either going to remove the plague entirety and graft, or incise on it and graft in between the space that will come. There are a lot of grafting materials that are available, either from the patient himself, from another human being, from other animals, or ones that are manufactured in the laboratory. So you will consider these patients for grafting, of course, when there is severe deformity which we said is more than 60 degrees, when they have this hourglass or hinge effects, or these are twisting penis, when the penis is short, because the other options that will be there will be plication, and with a short penis, it will be worse. And when there is extensive plague. So to look at this, I tried to get what has been done locally, but unfortunately, I was not able to get any. So I did a search in PubMed with those catchy words of severe Peyronie's disease and venous grafting. And I got 17 papers, some of which I'll share with you on what the rest of the world have done on this. So one of the papers was by William and his colleagues, but they looked at 24 men with Peyronie's disease. They did plague incision, and their results was 96% success in achieving a straight penis. They registered 96% success in maintaining the potency of their patients, and they concluded that this method is satisfactory. Other group of workers also in Taiwan also looked at this disease in 24 men. They also did a plague incision, and their results were 96% success in straightening of the penis, and also 96% success in maintaining the potency of these men. The other workers that have done something on this include El Saka, who did also plague incision, and their results are as shown. They also registered a very high success rate in achieving a straight penis at 96%. The residual curvature was 30 degrees in only 3%, and one of the patients had a residual curvature of 15%. 83% had reported no change in the penile length, and even others reported lengthening of the penis. Hamed and Metin also did some work on this, and they used the saphenous vein, and their results were as shown, 88.8% in straightening of the penis. Of those, the only 16.6% of their patients reported penile shortening. But despite that, they were still able to engage in satisfactory sexual activity.
About 2 minutes left.
33.3% of their patients reported loss of sensation, but it was short-lived. Other workers also did this, and these are some of the reported outcome from their work, and you can see all of them reported satisfactory results. So this is the pictorial of how they harvested the veins, the stray sutures to mark where there is the plague, and there is a H incision, and from there they were able to lay the graft. Postoperatively, our main concern in these patients is erectile dysfunction and loss of length, and this will be tackled with PDE inhibitors, which we can start at 10 days and continue in even 3 months. Also, penile stretching techniques, whether it can be done manually or using traction devices. The only complication that are reported in literature of significance is loss of penile rigidity, which usually will come because of either your dissection during surgery or the plague itself involving the dorsal nerve structures. Also,
should be concluding now.
Recurrence of the disease, which most of the times will come when you operated during an active phase of the disease, or you are using a fast absorbable suture. So to conclude, this technique is an effective way of handling severe Peyronie's disease, and it has a success rate of 88 to 100%, with the overall patient satisfaction of 75%. However, local experience is lacking, and we need to do more on it.
Thank you, Daktari. Our next presenter is Dr. SNK Waweru, who is a consultant urologist practicing at Mata Hospital in Nairobi, and he's going to take us through failed urethrotomy or urethroplasty. What next? Karibu, Daktari.
Good afternoon.
Good afternoon.
Thank you for bearing the heat, and I'm glad that you're all awake. The topic sounds great. Failed urethrotomy, failed urethroplasty, what next? I think we all get to that point as urologists. What do you do next? And one of my colleagues asked me, what are you talking about? Is it diversion, or what are you talking about? I'm just going to go back to the basics and perhaps offer a simple suggestion. So urethral strictures are among the oldest urological problems and common with a high morbidity. And of course, open urethroplasty remains a gold standard and requires time and expertise, and there is a high recurrence rate. Other treatment options are catheterization, like Willis has told us, suprapubic catheterization. You can have dilatation, which can be sequential using metallic dilators or filiform dilators, or you can use balloon dilatation, which gives you radiodilatation, or urethrotomy. I would like to talk about urethral balloon dilatation. It's a minimally invasive technique. It has less morbidity, technically simpler, as long as you can do a urethroskopy, you can pass in a guide wire, you can do this. Less traumatic than sequential dilatation, and can be done as a day surgical procedure. Urethral dilatation as a whole has existed since the 6th century BC. And so what is the theory about dilating? Urethral balloon dilatation dilates the strictured urethra in a radial force. You avoid traumatic shearing forces, less mucosal injury, reduced extravasation and spongiofibrosis, less bleeding, and less painful, of course, perhaps less recurrence of stricture. Is indicated for short urethral strictures below 2 centimeters, and of course is a good tool after uretrovesical anastomotic stenosis or stricture following radical prostatectomy. The technique is simple. It's performed under anesthesia. You can do under local anesthesia or general anesthesia or spinal. And really what you do is that you have a high pressure balloon. I use the X-Force, which is used for nephrostomy tract dilatation, and is a 6 French, and it has 3 lumens, one for contrast, one for ballooning, and one for passing a guide wire. What you can see there in that video is a guide wire passed, and then the shiny bit is a balloon, and then you inflate up to 30 atmospheres, and you can see it takes a short time. We do it, you gradually dilate that balloon or inflate the balloon over about 5 minutes, and then leave it there for about 10 minutes. And you have a resident like Dr. Awath, he wants to do it also, so you repeat again, and you can see there is no bleeding. We are deflating now, and you can see we have a lumen. So that is what we have. There are papers, some people use 18 French, there are people who use 24 French. I have used 30 French, and some of the papers that use 24 French show a higher recurrence rate. And so the balloon is deflated. You can use also fluoroscopy if you want to use fluoroscopy. And what you want to see is that the waist, the narrow bit dilates under fluoroscopy. I have two cases to present. Case number one is a case we managed with Willis Otele. There was a son to a consultant pediatrician, got pelvic fracture urethral injury. In 2018, we placed an SPC. And being a doctor's kid, we discussed what to do, and we found it fit to send him to the best. So we sent him to Pune, and he had anastomotic urethroplasty and came back, couldn't pass urine well. So my friend Willis did a DVIU. And when we discussed with the father, he still wasn't passing urine well. And I told the father there is a technique I'm not quite sure about, but if you're willing, we could try. And they came to my office. We did a Qmax of Euroflow, and his Qmax was 4.6 mils per second. And so we did a small mini DVIU just to allow the guide wire to pass through, and we did dilatation on the 9th of September 2018. I mean 9th of February 2019. And what you see there are his Qmax. We also offered CIC with an 18 French catheter. And you can see the first one was on the 15th of February, showing a Qmax of about 25, 26. And then the second one is after 2 months. And up to now, the boy is passing urine well, and he has no issues. He has stopped CIC, and he continues to be well. The second one is a 55-year-old military officer, actually serving, was referred to me in 2017 with a recurrent bulbar stricture and had anastomotic urethroplasty before referral. And by the stricture referred, we saw him. We did some more investigation. Prostate was 79 cc with a PSA of 3.5. We did TURP, DVU, and TURP, and the biopsy was BPH. But soon after, he restrictured, and the Qmax as of November 2019 was 8 mils per second, despite CIC. We did a repeat DVU, and CIC still, the stricture persisted. And in April 2020, we did balloon dilatation up to 30 French and continued with CIC. And his Qmax gradually improved from 16, and now he's doing 26.7 mils per second, and none of them has any positive post-void residue. And so that's what I wanted to share. I think it's a simple procedure, can be done as a day case. Those are the references, and I would like to say that I have no conflict of interest. I just thought we should share this. Perhaps, Willis, with your many cases, you would like to consider doing this. I think the balloons and the X-Force can be reused, and therefore can also be ideal in resource-poor settings. Thank you.
Thank you, Dr. for that presentation, and you've saved us a few minutes.
We'll now move over to Dr. E. Kimani, and he'll be taking us through factors influencing length of hospital stay after urethroplasty as seen in Kenyatta National Hospital. Welcome, Dr. And just as a reminder, the questions that we have, we do have a Q&A session of 10 minutes towards the end, at the end of the session, so make them brief, very precise.
Okay.
Karibu, Dr.
Good afternoon. My name is Dr. Ernest Kimani from Year 3, University of Nairobi, Year 3 Urology resident. And I'm honored to make a second presentation in this meeting. So I'm going to present on factors influencing length of hospital stay after urethroplasty. We know that urethral strictures are a common occurrence in many urology units in many hospitals, including KNH, and they're associated with significant urinary and sexual morbidity. It has an estimated incidence of 200 to 500 per per 100,000 population. And the treatment with the urethroplasty can often be frustrating to many patients and surgeons alike due to recurrence and other unfavorable outcomes, as other presenters have said. And why were we interested in length of stay? Because length of stay is a very important outcome in the acute post-surgery, and it reflects on other factors such as wound healing, patient-based factors, hospital-based care, and overall health system efficiencies. And it also can result in increased risk of hospital-acquired infections. For instance, in our hospital, last year, we had 2 patients who acquired COVID in the ward while they were undergoing urethroplasty. And these are risk to other patients, to spread to them, to spread to other healthcare workers. So this is a very important concept. Again, understanding these factors is important because you should be able to adequately plan and mitigate post-operative complications, reduce cost of hospitalization, improve patient satisfaction, and even overall healthcare outcomes. So we're going to present results of a study, of a retrospective cohort study that we did with 21 patients who operated between January 2020 and December 2020. And our main aim was just to assess these factors that influence length of hospital stay after urethroplasty. Our demographic characteristics, we had a mean age of 42 years, from minimum of 13 to maximum of 73. And this is consistent with the study done by Otele in 2017, 2018, and also Mugallo in 2013. They found a mean age of strictures to be around 42 years. On etiology, most were bulbar at 57.1 years, followed by membranous, penobulbar at 14, bulbar membranous at 9.5, and proximal penile at 4.8. Most of the procedures done were EPA at 76.912% compared to BMG at 23.8%. I think there is a slide I may start. These, allow me. Oh, on etiology, infection was most common with trauma at 33%, followed by traumatic catheterization. Idiopathic were 9.5, and post-URP was 4.8%. So on length of stay, our main objective of this study, we had 2 groups of patients. We had short stay patients who stayed for less than 14 days, and long stay patients who stayed for greater than 14 days. Short stay patients were 3, long stay patients were 18. Mean duration for long stay was 66 days. Mean duration for short stay was 5 days. On cost of hospitalization, this is just a scatter plot on how it was distributed. Here you have the cost. Here you have the duration of hospital stay, and this red line is a regression line when you regress cost against the length of stay. And this is pretty obvious that the more you stay in the ward, the more likely your cost of hospitalization goes up. So we looked at SSI and other wound complications. There was a significant contributor of longer hospital stay with a p-value of 0.014. The next was socioeconomic status, where unfavorable socioeconomic status was associated with longer hospital stay with a p-value of 0.041. Presence of urethrocutaneous fistula was also up, because this predicts maybe a complicated procedure and probably a more complicated stay. And also perioperative malnutrition had a p-value of 0.041. And possibly malnutrition is an indicator of other factors such as socioeconomic distress, chronic illness. Yep. On multivariate analysis, where we put all these factors together to try to assess which factors best predicted the length of hospital stay, we found that wound complications and malnutrition were the strongest predictor of hospital stays. Other factors like age, location of stricture, length of stricture, type of procedure, presence of catheter had no significant influence on length of stay. Although another study by Agarwal et al. In 2019 found also renal function not to have an influence on hospital stay, and this was similar to our study. So in conclusion, adequate patient optimization prior to surgery is important, and this include nutritional and even workup, and also meticulous surgical techniques, which may involve prevention of SSIs, and also promotion, or we need to enhance social protection for health for vulnerable groups, because socioeconomic status was as well associated with longer hospital stay. Thank you.
Asante Daktari.
Our next presenter is Dr. Sheikh, who is going to give a presentation on patient-related outcomes after urethroplasty at Kenyatta National Hospital. Welcome, Dr.
Thank you, thank you. Good afternoon.
Good afternoon.
Just to correct, it's patient-reported outcomes rather than related outcomes. Yeah. So this time round, we are assessing urethroplasty from the patient's perspective. So to begin with, just posing a question, how do we define a successful urethroplasty? And when you're defining a successful urethroplasty, are you defining it from the surgeon's perspective or from the patient's perspective? To answer this question, Mix and colleagues were the first people who did a systematic review, and they looked at the literature for the past decade. And they found out that 80% of the time, the literature defines successful urethroplasty as an absence of secondary procedure. As you can see, this definition has its own advantage and disadvantage. The biggest advantage being it's easily replicable, and therefore it can be used in a general population. The other advantage is that it requires little effort from the provider's perspective and also from the patient's perspective. The disadvantage is that it assumes the patient actually goes to the same provider. What happens if the patient goes to another provider? To that first person who did the surgery, it's a successful surgery. But if he goes to another person, it's not. And then also, it assumes that all providers will offer the same standard of care. For a surgeon who does routine cystoscopy for patients who have had urethroplasty, he will have a little threshold to intervene compared to the person who waits for symptoms. The other disadvantage of this definition is that it does not include the patient's symptoms and the patient's input. So there's an interesting study that was done by Kessler et al. In 2002, and they were looking at patient satisfaction with the outcome of surgery for urethral stricture. And in this study, 24 out of 30 patients, that's approximately 80% of the patients in whom urethroplasty was not considered a success from the surgeon's view. They considered that this was not a successful surgery, but the patients themselves were actually either very satisfied or satisfied with the outcome of the surgery. And therefore, this discordance is what we are trying to sort out. And that brings about the question of what we call asymptomatic recurrence. What do we do with such patients? There was also another study done by Brea et al. In 2017. He actually asked clinicians who deal with urethral strictures, who reconstruct urethral surgeries, of 15 symptoms that they consider most important. And then they went to patients who had stricture disease, urethral stricture disease, and they asked them, what are the 15 symptoms that you consider most important? Surprisingly, there was 54% agreement on what they considered important. But 46% of the time, there was a discordance. What the patient considered important was not actually important to the surgeon. And therefore, that introduces what we call PROMS, patient-reported outcome measures. And these are actually a set of questionnaires that we give the patients preoperatively and postoperatively to ascertain if the intervention that we did actually affected their daily function, process, or quality of life. For urethral stricture disease, which is a quality of life condition, therefore, the ultimate factors that drive the medical care should include the patient's symptomatology and satisfaction. So the first set of questionnaires that were used to assess urethral stricture disease were actually non-specific to the disease. And this included the IPSS score and the quality of life, which were initially developed for benign prostatic enlargement. Then came in 2011 and 2017, the first questionnaire that was developed was by Jackson et al. In what we call USS-PROM, and that's urethral stricture surgery patient-reported outcome measures, and it was developed by Jackson et al. And this is one of the questionnaires that's disease-specific. And the other questionnaire was USIM, which was developed by Brea et al. In 2017. That's urethral stricture symptom impact measures. And therefore, we did a study. That was a prospective study. We had a sample size of 65, and we used the Jackson et al. 2011 USS-PROM questionnaire, and we filled the questionnaire preoperatively and 6 weeks postoperatively. The data collection tool, which we call the USS-PROM, has mainly 3 domains. The first domain is the lower urinary tract symptom domain, and it has 6 questions, and the score is between 0 to 24, 0 being asymptomatic and 24 being the most symptomatic. In the quality of life domain, we use what we call an EQ5D, and it has 5 sets of questions, and the 5 sets of questions were scored between 1 and 5 with a maximum score of 25. The other domain was actually the overall satisfaction of the patients to the procedure. Quickly, just to move on, the results, as you can see, the urethral strictures, we had bladder neck, one patient, but majority of the patients were actually bulbar urethral strictures. The procedures that were done, majority of the patients had an EPA and augmentation urethroplasty. So, as you can see, just take one example of a question that we assessed, and that's frequency. As you can see, preoperatively, most of the patients were falling in between a score of 1 and 2. A score of between 4 and 5. And postoperatively, the score, majority of the patients had a score of 1 and 2. The interesting part of this study is what we call the level of satisfaction. That part was interesting because, as you can see, 13 patients were actually dissatisfied with the surgery that they got. And when we asked them from the questionnaire, why were they dissatisfied with the surgery? The answer was 6 of those patients were urinary symptoms because of recurrence of the urinary symptoms. But 7 did not have urinary symptoms, but they were still dissatisfied. The big question is, why were they dissatisfied? Is it because of the numbness they get after surgery? Is it because of the cosmetic appearance? Is it because of erectile dysfunction? So, therefore, you can see in conclusion, given that the outcomes of urethroplasty are very subjective and beyond urethral patency, surgeons should consider using this disease-specific patient-reported outcomes to assess symptoms and to assess patients' satisfaction. Thank you.
Thank you, Daktari, for that presentation.
Thank you to the presenters. They're doing quite well on time. We're moving on well. So now we're coming to Dr. Alwora Ken, and he's going to be presenting on neophallus reconstruction after traumatic penile amputation. That's the 3rd presentation on your session program for today, afternoon session program. And I believe he's with us virtually, and he's going to be presenting through the virtual platform. And as he does so, I also want to make a note to Prof. Mutambiro to be on standby, as he'll be coming immediately after Dr. Ken Alwora. Dr. Ken, are you with us?
Yes, I am. Can you hear me?
Thank you. Proceed.
Okay. Please allow me to share my screen. kindly allow me to share my screen.
You can go ahead, Dr. Ari. Try and share your screen.
Yes, thank you.
Okay, you can proceed.
Okay, thank you for the humble opportunity to present virtually. I wish we were there physically. On the case of penile reimplantation, essentially, this is a case we did 2 years ago, but we've never presented to CAUS, and we were the plastic surgery team with the urology team led by Dr. Ikol. My name is Dr. Alvara, as has mentioned. We received a patient, AM, 17-year-old male from Embu, who came with the mother, who was the informant. The patient had sustained traumatic amputation of the penile shaft, also had scalp lacerations, and also laceration at the left ear. There was reduced level of consciousness, and this happened at 1 a.m. On the date said, and came to Kenyatta, and this was 8 hours prior to arrival at KNH. This was the amputated part, notably. It was well preserved, as you can see. The challenge we've been having, and one of the reasons why these cases are not so common, is because the people who amputate the part usually flush them away. That is a sidetrack, but on history of presenting complaints, the patient was a referral from Embu County and had sustained traumatic amputation of the penile shaft, as I had said, and scalp and left ear lacerations. And he was assaulted actually by 4 persons known to him who were looking for the parents but found him. The patient was hit on the head, lost consciousness until the referring hospital, which was Embu. And at home, I think there is good knowledge that has gone around following the reimplantation surgeries. The amputated part was stored in ice, and this was at 1:30 a.m. Pressure was applied on the stump with a cloth and was rushed to Embu. He arrived at Embu 2 hours after the accident, was given analgesics, transfused a unit of blood, tetanus toxoid was given. Suturing of the lacerations on the ear and the scalp was actually done, and the vessels on the stump were clamped with the artery forceps, as I'll show. And now the healthcare givers at Embu, whom did a very good job, now preserved the amputated part in sterile gauze, put in a polythene bag, and then inside a cooler box, which is the current ideal. He was then referred to KNH, and he arrived at 9 a.m. At A&E in KNH, was reviewed at 9:30 by a multidisciplinary team comprised of the plastics, us, the urology team, general surgery and neurosurgery, and also the anesthesia team. Past medical history was unremarkable. The family social history, he's a Form 4 student. Actually, he deferred now. We saw him in the clinic on Tuesday. He's still in Form 4. I think he lost a year and also the COVID issues. And then both parents are alive and well and lives with them. He has 2 brothers and does not smoke cigarettes or drink alcohol. So in summary, we received a 17-year-old who was referred to KNH after traumatic amputation of the penis following an assault by non-persons 8 hours prior to admission. Physical examination, general examination, notably he was pale, and on his vitals were 124/60, the pulse rate was 73, respiratory was 13, SpO2 was 100, and temperature was 36.3. CNS, he had reduced level of consciousness, and his GCS was 13 over 15. The pupils were bilaterally equal and reactive to light. The scalp laceration was on the left temporoparietal area and the left ear, and both had been repaired. CVS respiratory and abdominal systems were all unremarkable, or normal, I mean. And on local exam of the stump, the patient had a clean cut amputation around the proximal penile shaft. The scrotum was edematous, but there was no injury. The stump had artery forceps clamping the vessels, no obvious soiling, and there was a hematoma. The urethra was not easily visualized. That was at Accident and Emergency Center department. The amputated part was well preserved in a moist gauze, as had been done at Embu. In a polythene bag in the cooler box, we opened it. It was clean, no obvious soiling. The corpora were visualized. This was a stump, and of note, you can see the artery forceps. You know how well vascularized the penile gland is, and I'm sure it was difficult for them to put tourniquet. It was at the proximal penile shaft. The only problem now here comes in because we're crushing the vessels, and anastomosis, that shortens the length of your vessels. But they still did what they could. This was the amputated part. As you can see, clean, no soiling. It was well preserved. A full hemogram uses coagulation profile, and a head CT scan was done. The HB was apparently normal, though he was pale. The UECs were also okay. Sodium was mildly high, 146. The only issue was in the CT scan, where he sustained head injury. He had left temporoparietal acute cerebral hematomas with perilesional edema and associated with comminuted skull fracture. He also had a left parietal extradural hematoma and fractures of the left squamous and petrosal bone. But the neurosurgery team was elected to manage the patient conservatively. The patient was stabilized and prepared for emergency exploration and reimplantation. So consent was obtained to the mother. We discussed about the possible outcomes, and they consented to the procedure. The neurosurgery team, as I'd said, managed the patient conservatively. Then the patient was taken to theater at 11:40 a.m., which was 10 hours after the accident. Put under GA, as the urology team did the suprapubic cystostomy, and then we prepared the stump, exposed it. The artery forceps were removed, and the corpora cavernosum deep arteries noted, and the tourniquet was applied. This was after the suprapubic catheter has been put. We've not removed the stump yet. This is just a cross-section and I've seen has just been presented, of the level of the penile gland. Notably, the superficial dorsal vein was very crushed, but after we prepared the stump, we got the deep dorsal neurovascular bundle. So the stump and amputated part were prepared, and the structures identified: the corpora cavernosum, the corpora spongiosum, and the urethra, and I'll show you in the next image. The neurovascular bundle was dissected out. Superficial dorsal vein was not so good because it had been crushed, but we identified it. The deep dorsal artery, the deep dorsal vein was good. Then the dorsal arteries and the dorsal nerves we also visualized and we repaired. So first we started with the anastomosis of the penile urethra, which was done using interrupted Vicryl 5, and then a silicone catheter was passed through the urethra. But this is just a preparation. You can see the corpora and the fascia, which has been lifted. And then the tunica albuginea, after the urethra was repaired, then the tunica albuginea was approximated using Vicryl 3. Notably, some
2 minutes to your
some
time,
people have
Dr.
tried to. Okay. Some people have tried to repair the cavernosa arteries, but there's no really difference, because us, what we did was the dorsal arteries and the dorsal veins we anastomosed them, and the dorsal nerves we also coapted with 9-0. Patency of the anastomosis was confirmed. The deep superficial arteries were closed in a single layer, and the glove drain was put. This is the after we finished the surgery, and you can see the glove drain. Protocol for management after implantation: we do 2-hourly monitoring of the implantation, which was done, and transfusion of the patient was transfused 3 units, analgesics, anticoagulants were given, but congestion was noted around 20 hours after the reimplantation, and the patient was taken back in. We re-explored, but we only found hematoma, and this was how it was looking. A bit edematous, and the blood when you prick was really dark, which shows congestion. The glands and the skin subsequently after the exploration were still noted to continue darkening, and we made a decision to allow complete demarcation before action is taken. And patients was taken back for debridement of the necrosed skin and the tissue superficial to the tunica. This was 17 days after implantation, and this is how it was looking. Notably, we lost the glands. Cleaning and dressing was done, and then when it was ready, we did skin graft. And then the catheter was removed 2 weeks after grafting, and the current complication is the hypospadias, and the patient was discharged. This was taken on table, which was beyond the scope of my talk, but this was an image taken on table before we tried to repair the hypospadias. Notably, the patient, when we saw him on Tuesday, he's actually doing well, and is even able to get erections and ejaculate well, but the problem is now the hypospadias. Lessons learned: public education is essential for successful management of these patients, and this can be seen after the patient, the amputated part was really well stored. Working referral system is mandatory because these services are not yet there, but and multidisciplinary approach gives the best results. Post-op monitoring is very important, as we were able to see the congestion. Then our implantation protocol will be essential for standardized care. And since we are still working on the referral system, we need to also train more specialists so that this.
Thank you, Dr. for that presentation. And thank you for standing in for Dr. Nangola. On a lighter note, I hope California is okay now that you're seated right in front of the Golden Gate Bridge. So I'll hand over to my co-chair to invite Professor Mutambirwa. Thank you.
Our next presenter, I hope he's online, Professor Shingai Mutambirwa. Professor Mutambirwa is the head of Department of Urology at Dr. George Mukari Academic Hospital and Sefako Makago Health Sciences University in Pretoria, South Africa. Is he online? Is a hello, hello, Professor. We are still sorting out. We, Professor, give us Mutambirwa, give us about 2 minutes. We are trying to sort ourselves on this end, and then we'll come back to you. Okay, let's take the technical team is trying to organize.
We got you. Can people hear me now?
Just, are you able to hear us?
Yeah, I can hear you pretty well, guys. Thank you.
Just a
My
minute.
screen sharing is not, I'm not allowed to screen share yet, but instead of twice, it does significantly decrease your complex with its issues going on. The race, whether Black Africans, because we know we're more likely to get prostate cancer up to 5 times. Most of the trials, we know that there's issues about the CAG as far as base pairs go, which can make a difference as well. But today, the basis of the talk is about genetics. I always tell my residents that if, like Einstein said, if you can't explain it simply, you don't understand it yourself. I hope I do sort of understand. I don't think I understand everything about it, but there's 1 or 2 things. So I'm just going to swing through, particularly for residents, about what genetics are. Now, remember, essentially, all that a gene is doing is producing a protein. So if you have a mutation, all that's happening simply is that you're getting a non-functional or missing protein. And that makes it much more simple to understand where genetics is involved. And again, to make it very simple, there are only 3 types of genes that are going to affect cancer. 1, oncogene. It promotes division. And if you have a mutated function, it's abnormal time or cell type. And essentially, there are growth factors that are involved, which are causing the cancer because of the oncogene. Tumor suppressor genes. They suppress cell division, obviously. They're checkpoints in molecules. And if that fails to suppress division, you can get a cancer. And the third one, DNA repair gene mutations, which are super important because they're the ones that are being most studied and the ones that we do have targetable drugs to use against them. And it's a repair of gene mutations. Remember, there's 2 pairs of 2 base pairs. And if it fails to repair mutations, which are happening all the time, it can lead to damage to the cells, which increases the risk of cancers, but it can also be a target to suppress cancers. So gene disease basically is 4 things: loss of DNA, gain of DNA, changes in the nucleotides, CAG, all that stuff, and epigenetic factors, which are essentially 3 things: histones, methylation, and non-functioning, non-protein code, amino acid coding RNAs. What are they doing? Well, if you have defects of these genes, you're evading apoptosis, you're having self-sufficiency of growth signals. For example, the Warburg effect, where you use more anaerobic glycolysis in cancer cells. Anti-growth signals, tumor invasion, metastases, limited replicative potential, for example, that means immortality, and sustained angiogenesis. And these are basically all being covered by the various genes that we've already had a word about. And it might seem simple when you look at the number of base pairs in the human genome. It's only 30,000, less than rice or corn. But the reality is that it's really like finding a needle in the haystack. There's so many base pairs which are involved in the various genes that are important. BRCA1 is huge for breast cancer, BRCA2 huge for prostate cancer, and the BRCA2 is even larger than the BRCA1. But there are some simple things we can do to assess the genomics. And one is family history. Remember that if you have first-degree relatives with prostate cancer or first-degree relatives with breast cancer, you're at up to 5 times increased risk again of developing prostate cancer. And remember, it's not just the breast and prostate. If you look at pancreatic, which is a lot to do with, which can be related to hereditary non-polyposis coli and leiomyomatosis, and Lynch syndrome, those can also increase the risk. So it's super important for us to assess and ask the patients if they have any family history. But even having said that, only a proportion of cancers, and prostate cancer particularly, are because of a genetic inherited abnormality. And there are so many that are coming out all the time. BRCA2, as I said, is the most important for prostate cancer currently. PALB2 is there. It's a proximal and associated with BRCA2. But going forward, we're going to have more and more information about the genetic profiles of our patients, not only for preventative, but also for therapeutic. For example, HOXB2. There are different ways that the mechanisms of the genes that are causing the problem with prostate are different. HOXB2 is with an AR repressor, and it increases almost the risk of developing prostate cancer, but it doesn't increase the risk of nasty prostate cancers, unlike BRCA2, which is only about 20% elevated, and various other drugs, things like, for example, TP53, which we now know is very closely related to castrate-resistant prostate cancer. Also, we must understand that there's a difference between germline and somatic mutations. Somatic is the one that's by chance, essentially, in inverted commas. Germline means that the person was born with it. And if you're looking at it from our purposes, BRCA2, for example, we know that about 12% of patients with prostate cancer may have an alteration of BRCA2. About 6% are going to be about half of them will be germline, about the other half will be somatic. But keep it in mind that if you're going to be doing germline mutations, that's coming from your white blood cells in the person's body, and the somatic are going to be coming from the tumor itself. So you have to keep that in mind. And there are lots of ways we can pick them up. There's some which are off the counter, which are, and there are some which are in laboratories like the one we use in Johannesburg. Some of them are pretty expensive. It can go from $600 to $6,000 for a test, but it's still extremely useful to do them in a number of patients. In fact, the NCCN guidelines have now said that essentially the majority of patients with metastatic and patients with castrate-resistant prostate cancer, patients with high-risk prostate cancer, patients with family history, which is essentially everybody that we're seeing, needs to have a genetic profile, not only, again, for their treatment or for their thing, but also for cascade for their relatives to make sure that they don't they get more screening for different cancers as well. And again, there are lots of things that we're looking for. We're looking for predictive and prognostic and various things. But for example, like risk perception, it's PSA, that's still probably the most important biomarker we have. Risk assessment, Polaris, Decipher, Oncotype DEPs, they're helping us to make sure whether we should be putting patients on active surveillance or whether we should be giving radiotherapy or radicals. Confirm DX, whether you do a biopsy and the patient comes out and they still have rising PSA, should you do a new rebiopsy? There's so many ways we can look at the aspects of genetic. And it's sort of like looking at a crystal ball. We need to decide whether this crystal ball is actually going to be assisting us in the long term. And I would argue that it is. This has been seen many times. There's changes in the treatment landscape of prostate cancer. This mixes and matches. There's radium, there's now lutetium, which is going to come out from the VISION trial. But all of these have a cost. And the thing is that, for example, I'll show a bit of data just shortly, but if you have a patient who has an intermediate risk prostate cancer and you do genetic testing and it shows that for example, like Oncotype DX shows that it's got a low risk, you can avoid giving radiation and androgen deprivation. All of these have a cost. And the point is that it's important for us to remember that when we're talking to our patients, although the outlay may be bad, it may benefit the patients at the end of the day. Similarly, we don't have great data for Black Africans. And most of the data comes from SEER data, which is West African particularly. We are now improving our outcomes, and a lot of my buddies and colleagues in Kenya are involved in some of these trials. But I think it's going to make a huge difference if we can actually identify specific genetic aspects for Black Africans in Africa, including the fact, like for our data from one of the studies, it shows that if a patient has metastatic prostate cancer and they're from Swaziland, Eswatini, Swati, they're more likely to have advanced cancer, but they're going to respond better to orchiectomy than to anti-androgens. So I think the genetics will help us to direct our treatments. Hopefully we'll pick the patients up earlier so we don't have such a big issue. Similar to the genetic changes that happen when adenocarcinomas, which are the 95% of the prostate cancers that we get, goes to mixed variants and up to small cell. And as I repeat, small cell, we now have pretty good data to show that P53 is, if from the original cancer, is more likely to lead to castrate resistant. It's important for us to look at these aspects. And with all the approvals that are coming out for different drugs, for be it immunotherapies, be it PARP inhibitors, without directing genetic information from either immunohistochemistry or from next generation, we're going to battle and we're going to be wasting money and time on a lot of our patients. For example, with metastatic castrate-resistant prostate cancer, P10 loss, P33 loss, and RB loss may be indicative of response to platinum chemotherapy, combination carboplatin or cisplatin, and ipatasertib, which is an AKT inhibitor, which was recently published in the phase 1/2 potential trial, can lead to significant improvements in overall response rates. The DNA damage repair genes, these are BRCA2, ATM, and these various other things. They are, this slide's a bit old, but it is FDA approved, and it works in up to a third of the patients who have it. And if you have that information, you can use it. Microsatellite insertion or a high tumor mutational burden is now a blanket approval by FDA for any cancer with MSI high, up to 50% response. This is huge for patients. TRK fusions, for example, lacrotretinib is also there, about 80%, but it's the numbers of genetics that we have to pick up may be a lot. Similarly, some of the data that's coming out is showing us that we may be wasting money if we don't do genetics and if we don't follow guidelines. For example, the CARD trial was comparing cabazitaxel and taxane. It's slightly different to docetaxel, but it works in a slightly different way. Compared to abiraterone or enzalutamide after previous abiraterone and enzalutamide, showed a significant benefit for using cabazitaxel and almost no benefit from switching from one expensive ARAT to another. Similarly, DNA damage. PARP inhibitors are huge. It's now FDA approved. The response rates, up to a third of the patients are going to be responding to this. It's an important thing, but we can only do that if we have the genetics. And in fact, the PROfound trial and various other trials have shown that if you can pick up the specific genetics, for example, in PROfound, cohort A had BRCA1 and 2 and ATM, cohort B had others, and then they compared the outcomes. Cohort A, BRCA2 was the main driver of this, had a significantly improved overall survival. In the intention to treat population, it was not as significant. It was still significant, but it was not as significant. So I think going forward, we need to assess the genetics of our patients. But in the back of our mind, I know we're saying, oh, these are expensive, there's this, that, and the other. We can't even afford olaparib or any of these drugs. But there's still some small things we can still advise to our patients to keep them healthy. The ABCDEs, awareness, aspirin, blood pressure changes, make sure they're on the right, they're checked, cholesterol, smoking cessation, diabetes, making sure they're on good treatment, dietary changes, and exercise can make a huge difference, including vitamin D for patients with metastatic bone metastases, calcium, exercise is important, smoking stop again, alcohol limitations, and the medications such as the bone protective agents, bisphosphonate, or which is mainly zoledronic acid, or denosumab. But to end off, remember, we have to change our outlook on how we treat our patients. Each of them can make a decision. If they decide to go for genetic testing, it's between you and them. We have to change our we used to be a paternalistic attitude and have a more shared decision making to make sure that everybody understands where we're going, why we're doing it. For example, in the US, if you do a genetic test, you're protected from specific things like life insurance and stuff like that. But you're not protected from being covered for various diseases. So you have to keep in mind that it's both between you and the patient. Geneticists are super important as well. They're very short in number for us, but they're important for us to include in our multidisciplinary team. And going forward, I think we'll eventually get to the point where we know the risks and the benefits, and we'll probably make a very happy patient. Thank you very much.
Thank you, Professor, for that discussion. I hope you still hold on the line as we are going to the question and answer session.
Yes, of course.
Now we
Yes, so it has come to our question and answer time. We'll make it very brief and give an opportunity of 2 or 3 pressing questions. Given I believe the media team has engaged the online platform, maybe one question virtually, and probably 2 questions from our audience. And Dr. Loro and Professor Mutambiro, we ask you to stay on for a bit. And for the other presenters, be ready to engage the audience. So I think Professor Mungai has a question. The mic to Professor Mungai. Kindly state the question and the presenter it is being addressed to. Thank you.
Thank you. This is to Shingai. Hi, Shingai. Now, you and I are looking at that study of the genetics of prostate cancer in our part of the world and what this is going to impact on the care of the patients in this part of the world. The one thing I wanted you to talk about is the influence of the environment on the use of genetics in the care of patients with prostate cancer. Thank you.
Thanks, Peter. And again, you're exposing our collaborations. You could answer this far better than me because you've done more work on this than me. But the point is that the environment is super important as well. I know that Rihanna Bornman, who's one of our collaborators, has been heavily involved with the northern part of South Africa, which is Limpopo. And they have a big issue because of DDT for the malaria and stuff like that, which has influenced a number of factors, including hypospadias, intersex, and undescended testicles. And so we know we have one of the highest incidences in the world for that area, and we suspect it's a lot to do with that environmental factor. But also, when it comes to prostate cancer, it seems to be having some impact on our patients long term. And remember that DDT, for example, has been banned in most first world countries. It's still necessary, I guess, in some of our countries at the moment going forward. But the environment is super important as well. And I don't think that it should be underplayed, that genetics can also be used for that as well. For example, investigating changes as the patients go forward. For example, with testicular cancer, we know that it causes immune senescence when you give patients chemotherapy for testicular cancer. And I think we're going forward with the same thing. But thanks, as my collaborator, I'm just going to not go too far. I think they can read your papers as well. Thank you.
Dr. Wambani there, he has a question.
Question for Shanghai and another one for Dr. Oluoch. Shanghai, can you just tell us how genetics influence sequencing of therapy in metastatic castrate-resistant?
That's a great question, and the short answer is I don't know, okay, because nobody really understands it. But the point is that I think, like, when you're looking at some patients, for example, who have got all the trials that have been done, like for example with PARP inhibitors, have been after previous chemo and or androgen receptor modulators. But I think one of the things that we picked up a lot is that if you do have a BRCA mutation, you're less likely to respond to docetaxel. In fact, you might have poorer outcomes when you get onto a PARP inhibitor. So I think going forward, it's going to make a huge difference. But currently, I think the genetics will help us more to just include patients on specific medications which are approved or should be approved. For example, PARP inhibitors and carboplatin seem to have similar outcomes, and with carboplatin so much cheaper. It might be worthwhile to get a BRCA done beforehand, just to decide if you're going to be doing that or one of the other DDRs mutations.
Can I ask my question to Dr. Oluoch? Dr. Oluoch, regarding your study, your presentation on venous patch on Peyronie's disease, the work done by Hamed El Saka from Suez Canal, I think, what were his outcomes? Were they based on functional outcome or cosmetic outcomes? Because he's reporting a success rates of above 90, based on what? Was it functional or cosmetic?
Thank you, Dr. Wambani, for that question. All the papers that I looked at, the researchers were looking at the potency, the rate of straightening, and any residual loss of sensation, not cosmesis.
Any other burning question to the presenters?
My question goes to Dr. Otele. Of the patients who developed strictures either after SPC or endoscopic realignment, the strictures that developed, which group had complicated strictures? So that then you can decide the best thing is an SPC or endoscopic realignment. Did you have such information from your study?
Thank you, Charles, for that question. I read your body language and I saw that question coming even before you spoke. I'd like to say that most of these ones who had complicated strictures were from SPC, but I've told you that that study has some flaws, the selection. We took 40-40, but then we became impatient at the tail end of the study, the 15 extra. The total was 95, the 15 extra, 40-40 in each arm, but the 15 extra for failure to get theater, and you are with a patient who is like in an acute setting, needs some kind of intervention, acute but stable. Remember, these were only stable patients. And then again, when we are selecting patients, we are just doing very simple randomization, alternate. We say the one for SPC fits the first one, the next one would be the one with the opposite condition. So sometimes it looks like we may have selected inadvertently patients with partial injuries or patients who would have just healed to go to endoscopic alignment. Maybe we are just aligning something that may still heal on its own. So there's that kind of thing of selection bias, but the tendency for the more complex, and how do I know that they are more complex? The ones which are long segment. A complex stricture by definition would be length of the segment if there are added factors like fistulation, cavitation, false passages, or even displacement, lateral displacement of the prostate. Those by nature would be complicated strictures. Or if you are intra-op, if you fail to locate the prostate apex, or if you have extensive fibrosis around the area where you're operating, then that constitutes a complex stricture. Then added to that list are double obstructions. There are some strictures where you find that there's obstruction at different points. Obstruction and a patent segment in between. So those by nature tended, I mean, just without any obvious reason, they were from the arm that was done SPC. Does that answer your question? There's a second one. What was the second question? So they tended to be most from the SPC group for a reason that we cannot tell. But I've told you that there was a bias towards the end. We opted to just now give them SPC because of an availability of theater for endoscopic alignment. You know the situation of theater in KNH.
Thank you. And I believe we have to come to the end of session 6 and give an opportunity for the sexual health and andrology session. Given that we are pressed for time, but I believe we can make it brief, just a minute for the question to the presenter.
Yeah, my question is to SNK Waweru. Dr. on the child that you sent to Pune, your statement is a bit disturbing because you said you reviewed the patient with Dr. Tele and you thought that the best place for this child to be handled is Pune. Whereas I believe that you could have handled this child. So that statement to me is a bit disturbing.
I think, right, as a colleague's child, yes, we can do these procedures here. Dr. Otele can do perhaps better than me. And, but we discussed being a colleague's son, and the guy was asking for the best care for his son. We gave him the options. We can do locally. It can be done in India. He elected to have it done outside, and we just facilitated.
Thank you for that final question. I believe the media team has engaged the online chat, and you can always ask the presenters the questions, those who are logged in virtually. So thank you. And that brings us to the end of session 6. And I thank my co-chair, Dr. Moro, for chairing with me. Thank you. Any housekeeping issues, Dr. Ikol, before we get to the next session? So I'd like to invite Dr. Misango and Dr. Otele to chair the next session on sexual health and andrology.
Thank you. I think sometimes I get technologically challenged. Now, we are approaching the final, we are at the tail end of this conference, and I think it's only appropriate that we end with a session in andrology or sexual health, because these matters usually come at the end of things. If it had come any earlier than this, I think that would have been a premature ejaculation. So it's a good place to start. Now, this session on sexual health and andrology will be chaired by me and Dr. Otele, and we'll get the first presentation from Dr. Wahome. I believe he's here. Dr. Wahome is a clinical psychologist at Mpisha Hospital. That's what I've been made to believe. Thank you very much. So, without further ado, Dr. Ari.
Thank you, Mr. Chairman. I'm happy to be here in this particular conference to have some sharing on male sexual dysfunction. And basically, we are going to have the experience during the COVID-19 pandemic. I'm here, of courtesy of Dr. Aban, who invited me to come and share with you. So I wish to take a few minutes to talk about those issues. Now, all you know is that what we are going to discuss in this particular presentation is about sexual dysfunction among males, as noted during the COVID-19 pandemic, and also the type of male sexual dysfunction, clinical experience with some of the patient, and the therapeutic interventions that we can actually be able to discuss or look at. As you all know, in the nature of all pandemics, there is usually the issue of disruption of normal life. And as you all know, when COVID-19 came, there was a lot of fear. All the newspapers all around were awash with news of death and infections and all that. So there was general fear among the public, and this actually affected people's way of life. What followed next is what we call violent lockdown, physical isolation, and as a result, a lot of business came down, and that resulted to a lot of economic pressure and job insecurity that reduced family income and also had social security issues in the family. Anxiety and depression became a thing that we started seeing as people became helpless and hopeless due to the situation they were in. Now, let's look at what is sexual dysfunction. In a nutshell, I'm sure I don't want to dwell so much on this, but we know it's a problem that can occur during the phase of sexual response cycle. And when we talk about sexual response cycle, we talk about the excitement, the plateau, the orgasm, and the resolution. And sexual dysfunction prevents anybody from enjoying the sexual experience. You may be the one complaining, or the partner may be the one complaining. Who is actually affected by the sexual dysfunction? We say sexual dysfunction can affect any age, but it is much more common from the age of 40 as people start getting old. Now, common sexual dysfunction, basically we talk about the excitement, the plateau, and the excitement, basically we have talked about the issue of erection, ED, also the issue of plateau, the issue of premature ejaculation or delayed, or what you call a situation of orgasmic disorder and resolution. And why is this issue quite difficult? Because this is not matters that we discuss quite more or quite common in our society. You realize most of the time, society or traditional issues don't talk about sexual dysfunction. In fact, you look petty if you are really discussing about this issue, or if the wife has to go back to her parents simply because the husband cannot deliver. She may complain of other issues, but not basically sexual issues. So many people suffer in silence, and some of them actually resort to what we call self-medication. Others resort to some spiritual activity, natural herbs. I'm sure I've seen many people trying to use some of the natural herbs available, aphrodisiac and that, and also others seek treatment. But you find out for people to be pushed to treatment, that is where difficulties are, and they may have had a lot of discomfort. What are the symptoms of sexual dysfunction, especially in men? Basically, we are talking about inability to maintain an erection hard enough for sexual intercourse, erectile dysfunction, and then absent or delayed ejaculation despite enough sexual stimulation, what we call retarded ejaculation, and inability to control the timing, early or premature ejaculation. I think the chairman alluded to that quite earlier. Now, causes of sexual dysfunction basically are two. They are what we call the physical causes, and I'm sure most of the issues discussed in this conference, especially when we talk about the penile issues, the injuries, the trauma to it, all these are kind of the physical issues. But when you talk about the physical issues to the sexual dysfunction, basically we talk about other medical conditions, including diabetes mellitus, including heart and vascular disease, neurological disorder, hormonal imbalances, and also other chronic diseases, including liver and kidney disease. Alcoholism and drug abuse has also been seen to be having this kind of thing. And again, side effect of some of the medication that you give to patients, especially antidepressant or maybe hypertensive medication. Those are the issues that we have seen. When we talk about psychological causes, what we are talking about, stress and anxiety has been to be one of the leading causes of sexual dysfunction. And you know the situation of COVID-19 brought that particular issue in our society. Then the other issues is marital and relationship problems, depression, feeling of guilt, and what we call body image issues, and the effect of past sexual traumas. This has been common, especially to people who have gone through past sexual traumas. Now, how is sexual dysfunction diagnosed? It's actually quite difficult because usually you not see people coming to the clinic because they have a sexual dysfunction. Either they come in when it's so difficult, especially for men, they will come in because the ED is really affecting them. Probably sometimes you may see the wife coming to complain, or they go to a clinic, and then in the course of the doctor, maybe urologist looking at his problem, then refer to them for psychological management. That is the time you can see them coming. So as a result, it becomes a difficult condition that makes people come for help. The other one is what you call self-assessment. Individuals realize they have a problem during their sexual activity, and from there they can start looking for help. Then sometimes you can have diagnostic tests, especially to rule out whether there is any medical condition. But it's important when patient comes for this particular, with this particular complaint, one of the things we need to look at is to have an evaluation of our attitude toward sex, basically the issue of fear and anxiety, whether there is any past sexual trauma, and also the issue of relationship. And then, of course, is that person on any medication? Because, as we said earlier on, some of the medication could cause the side effect. What is the impact of COVID-19 on specific sexual dysfunction? We noted about 4, and we are going to quote a few studies that were done. Sexual desires and sexual discrepancy, a problem that was noted. Erectile dysfunction was also noted during this time. Orgasmic and ejaculatory disorder, and genitopelvic pain penetration disorder, what we call GPPBD. Now, on the sexual desire and desire discrepancies, it was noted during this particular period of time, and especially this study was done by JMed Internet Research 2020, that there was a change in sexual behavior for couples younger than 35 years old. And basically this was a decrease in their sexual desire, leading to a lot of issues in their relationship. And as you know, the issue of sexual desire and sexual discrepancy is what brings many people for psychological support in a clinic. So you'll see people saying, I have the desire, you don't have the desire, you seem to have given up, and some of these complaints makes people come. So it was noted during this particular period that some people tend to have kind of decreased desire. The other one is orgasmic and ejaculatory disorder. And we all know the etiology of orgasmic and ejaculatory dysfunction often include stress, anxiety, and preoccupation. This was done by Cohen and Godestein in 2016. So in both men and women, When there's psychological distress, then we are likely to know this particular problem. The other one was ED, which is the most common male sexual dysfunction, affecting about 13 to 28% of men. This study was done by Rumen in 1991. And we know that a man has to have good nerve function, adequate hormonal testosterone levels, adequate blood flow, and a willing mind to have a normal erection. When these things are not working, then you see some of these problems. And we noted that during the COVID-19, there was a significant amount of stress that affected the people in terms of their psychological state. And this would have some issues regarding their sexual desire. The other thing that we noted in sexual erectile dysfunction, basically they came up with three issues what are noted. Vascular defects. COVID-19 can cause hyperinflammation to the heart and surrounding muscles and affect the blood flow supply to the pineal organ. Then also psychological impact, stress, anxiety, and depression affect the mood and the emotional response and overall health deterioration as a result of people who have COVID. Now, these are there's also the genitopelvic pain. This is basically more common with women, with about 10 to 28%, but men are less common in that. Post-traumatic, these are people who have gone through some trauma as a result of sexual abuse. But when we are going to look at the studies that were done and the focus on those studies, we noted that during COVID-19, there was a presence of anorgasmia and erectile dysfunction. Reduced sexual desire was also noted. And in our local study, which we did in our hospital, in MP Shah Hospital, we noted some sexual desire discrepancy among people with a difficult relationship and also those who had COVID. We are going to share that shortly.
Doctor, you have 2 minutes.
2 minutes. So what are the recent studies? Basically, we have one study that was done, and we already shown some kind of sexual dysfunction that we have already noted. We don't need to dwell on that. We also noted that with the COVID-19. But let me go to what we saw in MP Shah Hospital. Among some of the 6 patients that I don't know whether we are able to see that we were able to look at, there were issues that we noted. Most of these patients were aged between 29 and 63 years. All of them were men. They are working, and most of them came with either ED, sexual desire discrepancy, and we noted that most of them were in sexual relationship, especially, only one who was engaged. What did we find out in this study? ED was most prevalent condition due to a distress it causes, and 50% of the patients sought treatment of their own. And successful treatment of this condition depended on multidisciplinary approach. And most ED problems were resolved successfully when both partners were involved, and that was quite good. Presence of relationship conflict was also seen to be a contributing factor, not just the COVID itself, and more than 50% of the patients had comorbidities such as diabetes, hypertension, alcohol abuse, and this one exhibited the sexual dysfunction. Most patients who have recovered from COVID-19, this study had a sexual dysfunction problem, one of the type or the other, and we need more research to be able to find that because the data was very small. We say it was retrospective study, the sampling size was small, and it was limited in number, and we hope this can be replicated elsewhere we get the good result from that. So in conclusion, we say treatment for this particular condition, we have to use medication, psychotherapy, and basically what we call CBT sessions so that we can deal with issues of anxiety and depression, and also education among those affected. So finally, we can say then that COVID-19 has significant impact on sexual dysfunction, particularly erectile dysfunction, and physical and psychological factors should be considered when diagnosing and treating sexual dysfunction. Relationship issues and economic pressure contribute immensely to anxiety and depression besides COVID-19, and treatment approach should take the wholesome approach in addressing the psychological and physiological etiology. And we need more research because COVID-19 is new. Most of people are not coming up. We need more research so that we can be able to understand the real factor beside this particular group of people. Thank you very much.
Thank you very much, Dr. We are going to be very strict on time, so please arrange your presentation to be able to fit into the 10 minutes. Dr. Nyaga is our next presenter. Dr. Nyaga, that is E. Nyaga, consultant urologist at the Meru. Remember, he hosted us last year. Today, he's being hosted by some other people. So, Dr. Your 10 minutes start now.
Thank you, Chair, for introducing me, and I wish to thank the management of KAUS for giving me a chance to do my presentation. I'm going to present on erectile dysfunction, specifically on a PDE5 inhibitors, and when they fail, so what next? I have no disclosures. We know that the current availability of safe oral drugs in conjunction with the tremendous media interest for the male sexual dysfunction has increased the number of men seeking help or treatment for ED. The incidence of ED is difficult to define, but we would say that it increases with age, as the previous presenter has said, and this is may be likely due to a decline in the cavernoso smooth muscle concentration and also age-related vascular leak. Geographically, those areas that we find high incidences of or prevalences of smoking, obesity, and diabetes or hypertension, you find that the incidence of ED tends to be higher. So if we look at, again, one of the most quoted studies, that is the Massachusetts male aging study, it was reported that overall the prevalence of ED among men aged 40 to 70 years was over 52%, with this increasing to about 70% in those men who are aged about 70 years. The etiologies of ED could be many, and we can talk about them being being vasculogenic, neurogenic, all the way to drug-induced, and also being psychogenic. Now, these proposed ED etiological and pathophysiological factors should not be considered prescriptive. Why? Because ED is associated with multiple pathophysiological factors, often, if not always, and will always have a psychological component in it. Most men with ED do not receive treatment. Why? And it's estimated that about 75% of these men will not seek treatment. There are some potential reasons why the men will not come for treatment. One is that they will feel ashamed, or sometimes they will feel that the doctors or the clinicians will not take their sexual problems seriously, or sometimes the clinician does not actually introduce the issue or address the issue. So what are men looking for in their ED treatment at this time, or this in the year 2021? Most men will be looking for cure for their ED. Other men want they want pleasure, they want partner satisfaction, they want reproduction, they want naturalness, they want control. Men also want to last longer, and more so, they also want spontaneity in achieving the sexual desire. So when it comes to management of ED, we can talk about various pathways or various things that we can be able to do. And one of those is that sexual counseling is very important, as has been said by the previous speaker. That is, if no organic cause can be found for the dysfunction, oral medications, injected or implanted or topically applied medications, external vacuum constrictors, and surgery. So if you look at the guidelines that we have, you can be able to see various approaches to the treatment of ED. And you will find that some of the approaches include what we would say that the first-line therapies, the second-line therapies, and the third-line therapies. The first-line therapies, like the oral PDE5 inhibitors, are widely available, and these are prescribed both by the urologists and the physicians, and even the primary care physicians. So most of the time, by the time the patient is coming to you, they will have either tried these medications over the counter, or they will have been prescribed somewhere else. But if you look at the second-line therapies and the third-line therapies, mostly these are available or are given by the urologists. The medical therapy for erectile dysfunction was revolutionized in 1998 with the discovery of or the introduction of sildenafil. But over the years now, there are other drugs that have come into play, and all these drugs are there in the market. But what we have to say is that there is no data that is available from either studies, double-blind or triple-blind multi-center studies comparing the efficacy and or the patient preference for the PDE5 inhibitors. So what about the choice of a particular PDE5 inhibitor? What influences the choice? The choice may be influenced by the frequency of the intercourse. You might have an occasional user or a regular patient who requires regular therapy, and also the patient's personal experience. There is something, sorry about that slide, my knees a bit dark. Continuous use of PDE5 inhibitors. We can say that the issue of continuous use of PDE5 inhibitors has been shown to improve or prevent the intracaverous structure alterations due to aging, diabetes, or surgical damage. And we know that the tadalafil is now available in the market at 5 milligrams once daily, and it has been shown to improve erectile function outcomes among men who are under partial response to on-demand PDE5 inhibitors. Also, continuous dosing may also be used in the comorbid patient who has LUTS and erectile dysfunction. What about those patients who fail to respond to PDE5 inhibitors? They may fail to respond because of incorrect use of drug, lack of efficacy of the drug, or because of the many counterfeit drugs that are there in the market. The incorrect usage of these drugs may be due to failure to use adequate sexual stimulation even after taking the oral drugs, or failure to use adequate dose of the drug, or failure to wait for an adequate amount of time between taking the medication and attempting sexual intercourse. We have seen that data suggests that an adequate trial with a PDE5 inhibitor might involve at least 4 to 6 attempts with maximum dose of a particular drug.
You have 2 minutes. Sorry for sending you off your tracks, Dr. but
no problem.
Just a reminder.
So, what about those patients who are correctly using their PDE5 inhibitors? Evidence has shown that you might have to look at some of the patients who have late onset hypogonadism for testosterone replacement, or you can switch to a different PDE5 inhibitor. If the drug treatment fails, then the patients should be offered alternative therapies. And some of the alternative therapies that are there include the intracavernosal therapy, whereby you get prostaglandin E being injected into the intracavernosal with a small syringe like the insulin syringe. You can give the Muse, okay, the medicated urethral system for elections. Okay, this is injected into the urethra. Then you can have the vacuum erection devices that are also available. And the essence of vacuum devices is that they draw blood, and then you are able to achieve an erection. Then penile prosthesis. These ones are available as either 2 or 3 piece. You can also have the malleable and the mechanical prosthesis. They are quite expensive, and these are indicated in those patients who are not suitable for these other forms of therapy. Of late, you'll hear about low-intensity shockwave therapy, which is not fully recommended, but is still is there in the market, and has been shown to also bring some correction to patients who are having problems with ED. So my last slide, what we have to say is that there is a role of prevention for ED, as the first speaker has alluded to, and this is comes in the optimal management of diabetes, heart disease, and hypertension, and also encouraging some of these patients to be physically active and physically engaged. So the question is, how available are some of these modalities of treatment other than the oral PD5 inhibitors? How available are they in the market? I think that's the big question to us as urologists and as a CAUS, because most of these devices are available in the back street, and I feel that some of our patients are not getting the best. Thank you very much.
Okay, thank you, Dr. Nyaga. We will go to the next presenter. That is Dr. Musau. Dr. Musau is not a stranger to most of us. He's a consultant urologist at the Moi Teaching and Referral Hospital. And so we are having a presentation on paraphilias when sex becomes problematic, right? Right, so Dr. Musau, please go ahead.
Thank you very much. Yesterday, under the incitement of the advice we were given by Dr. Matu, I went to see the rock, and I realized that you require more than just hate for your gender to have it changed. So I want us to share about paraphilia, and this is just to remind you that you need two. It requires two to tango. Every adult understands what sex is, and so I'm not going to belabor the definition because we all have our own definitions, we all know what it is, and so I'll leave it at that, and we agree that it is the intricacies before, during, and after that attract discussion. Sex is driven by an erotic arousal whose eventuality is determined by the two opposing forces, that is the sex excitement and the sex inhibition. The sex excitement is neuroendocrine and is mediated by hormones, nerves, and vessels with the principal involvement of the mind, the eyes, and the nose as sources of stimuli. And unlike what our noisy neighbors make us believe, hearing is not a strong trigger of sexual arousal. The SIS, in turn, has two components. That is the fear of performance and the fear of the repercussions of the performance. So the SES and the SIS, the interplay between these two, will now determine whether you'll end up with the arousal or not. And all these will also determine the intensity and specificity that will vary between people and times as well. The paraphilias we are going to talk about, etymology is the history of words or the origin of how something is named. And so paraphilias have a bearing on the Greek words I could not pronounce, but in English it reflects para, which is besides or around, and philia, which is love or relationship. And every society has its norms that are in turn determined by culture and the evolving trends over time. According to the Diagnostic and Statistical Manual, volume, I think this is the version 5, for mental disorders, paraphilias are sexual arousals due to atypical objects, situations, fantasies, behaviors, or individuals. They are not mental disorders, and the wide view is that every human being has a unique sexual deviations that qualify for a kinky episode when viewed by others, but totally harmless to self and partner. Paraphilias become of psychiatric interest only when they cause distress or impairment to the person or become harmful to the partner. The case report is about Mr. Ekiru, whose initials are BAE, which sounds like Bay. He presented as a 23-year-old male patient with 6 weeks history of suprapubic pains, hematuria, and irritative LUTs that had worsened over the preceding 2 weeks. He had enjoyed a relatively healthy living with no chronic illnesses and no past admissions or surgeries. He's a second born of 7 siblings, an itinerant laborer who had worked in hair salons, shaving or dyeing hair, briefly did painting of houses, was involved in welding fabrications, and was jobless as of the time he fell ill. A month earlier, he had parted ways with his third girlfriend, with whom they had related for about a year, and after being left, he resorted to drinking a lot of alcohol and smoking bang. Physical exam revealed a patient in good general condition and normal vital signs, the key findings being a suprapubic tenderness with no rebound or guarding. He had normal bowel sounds on auscultation. The investigations revealed features of infection on hemogram. Urinalysis had proteins and blood, and on microscopy showed pus and red blood cells. There were no derangements on renal function. And the KUB initially had been reported in the referring facility as a complex suprapubic mass of urinary bladder origin, measuring almost 7 by 7 by 7 centimeters, was reported to be having an internal calcified thick septation and a wall thickness of 0.75 centimeters. A second ultrasound that we did in the referral facility for clarity purposes was reported to be a urinary bladder with thickened wall of 1 centimeter and containing multiple big calculi, the smallest being 5.2 centimeters long. So we decided to do cystolithotomy, and the bladder was approached through a pharyngeal incision and opened extraperitoneally. This is what we found. Your ordinary electrical cord with the wire having been removed and nicely threaded erotically into the urethra and coiling in the bladder. Those who are investigative enough can recognize that might look like me, and that is the cord on stretching. Except for mucosal inflammation, the bladder was normal. That cord measured 105 centimeters, that's 3.5 feet, and had a diameter of 0.5 centimeters. Bay had an uneventful postoperative period and was discharged home 10 days after surgery, a period during which he had psychological counseling and was to continue as an outpatient. Sexual arousals vary from person to person and from one time to another, as does the level of arousal. They may be somatosensory, visual, olfactory, and in a limited manner, auditory. When sexual arousal is achieved by or dependent on atypical stimuli, it is referred to as fetishism or paraphilia. The cause is not known, but paraphilias have been shown to be influenced by birth order, especially where you have a number of brothers ahead of you, left-handedness, and a possible higher levels of intrauterine exposure to estrogen. They have their onset during adolescence after being conditioned early in life by an event. Paraphilias can be optional, where it is an occasional in place of, can be preferred, where it is preferred over the normal, and can be exclusive when it takes over the normal source of arousal.
You have 2 more minutes.
Paraphilic people tend to be paraphilic people tend to be labile in relationships and find it having a paraphilia is a necessary but not sufficient condition for paraphilic disorders. There are over 500 paraphilic listings and only 8 paraphilic disorders in the DSM-5. The disorders are voyeurism, exhibitionism, frotteurism, where you find people, like it used to happen the days that people would be so packed in KBS, a guy decides to pick on his favorite choice of eroticism, and every corner, every bump will be rubbing himself on that person. That's frotteurism. Sexual masochism, sadism, pedophilia, fetishism, and transvestic disorders. The paraphilic patient without any of those disorders might only need counseling, as happened in this case, to preempt the likely progression to disorders and need for mental health care. Those are my references, and it has also been published in the East Africa Medical Journal. Thank you.
Thank you very much, Dr. Musau. Maybe during the question and answer session, you will be able to let us know whether Bay eventually got a Bay or is still engaged in his alternative sexual pleasures.
We are very well. The next presenter is Kea Amadi. Kea Amadi is a practicing urologist at Kabarnet, Baringo County Hospital. He's here to present a paper on fertility preservation in young men undergoing cancer treatment.
We are going to go through fertility preservation in young men undergoing cancer therapies. As we know, there have been remarkable advances regarding the treatment of cancer, whereby pediatric and reproductive age male patients are surviving for a long time. And the major quality of life issue that is coming up is the ability to produce and raise normal children. As we know, surgery, radiation, and chemotherapy may achieve relatively high remission rates and long-term survival rates, yet they are often detrimental to male fertility. Okay. It's detrimental to male fertility, and fertility may be affected by mechanical or toxic insults directly to the gonad, its innervations, or vascularity. Additionally, it may be impaired by radiation, cranial radiation, while treating brain cancer. For spermatogenesis, in the prepubertal male patient, usually have type A spermatogonia, and this type A spermatogonia is usually divided into the A dark and the A pale spermatogonia. Prepubertally, this type A spermatogonia undergo mitosis to fill the seminiferous tubules. Once the male child reaches puberty, the type A spermatogonia, the A dark spermatogonia becomes mitotically inactive, and the A pale spermatogonia continues to be mitotically active. Now the type A pale produces the type B spermatogonia, which here we can see goes on to produce spermatids, which undergo spermiogenesis to produce sperms. The type A spermatogonia also produces other type A spermatogonia mitotically so as to replenish the cells that undergo meiosis to form spermatids. So the importance of the type A dark and the type A pale is that the type A dark spermatogonia can act as a reserve after injury to the testis. So this balance between the mainly quiescent A dark and the mitotically active A pale spermatogonia is only significantly altered if, for example, a gonadotoxic insult leads to the loss of a larger part of the B and A pale spermatogonia. These B and A pale spermatogonia replicate. They replicate at a quick rate, and that's why they are affected. After such an insult, the A dark spermatogonia become mitotically active and also differentiate into A pale spermatogonia. This leads to a decrease in the total number of the A dark spermatogonia in the testes, to a recovery of the A pale population, thus potentially to regeneration of the spermatogenic activity. So the effects of cancer treatment on the male reproductive function. First, there's the chemotherapy-induced damage to the testes, and the germ cells are usually extremely sensitive to several classes of chemotherapeutic agents. And the impact of combination chemotherapy on the spermatogenic epithelium is usually dependent on the type and dosage of the drugs used. Alkylating agents and combination therapies in general damage the seminiferous tubules more, and they do it in an age-dependent and dose-dependent manner. Leydig cells are more resistant since they have a low mitotic rate. So here we have the gonadotoxic chemotherapeutic agents. We have those with a high or moderate risk for reducing fertility, and we have those with a low risk of reducing fertility. Those with a high risk are usually non-cell cycle specific drugs. For example, we have alkylating agents like cyclophosphamide, busulfan, melphalan, chlorambucil. You have platinum agents like cisplatin, and the mechanism of action is usually direct DNA and RNA damage, and they also induce apoptosis. For the low-risk chemotherapeutic agents, the cell cycle-specific drugs include antimetabolites like methotrexate. You have vinca alkaloids like vincristine, asparginase, and the mechanism of action includes DNA and RNA synthesis inhibition, inhibition of mitosis, and deamination of proteins. For non-cell cycle-specific drugs, you have antitumor antibiotics like bleomycin, which cause induction of DNA strand breaks. For irradiation-induced damage to the germinal epithelium, the germinal epithelium is also very sensitive to radiation, and the damage depends on the field of treatment, the total dose, and fractionation. You may start getting short-term cessation of spermatogenesis with doses as low as 0.1 gray. 2 to 3 gray may cause long-term azoospermia. Doses of more than 6 gray can deplete all the spermatogonal stem cell pool and lead to permanent infertility. Fractionation increases the germ cell toxicity, and this is possibly because of repeated hits activate the A dark spermatogonia, and thus it repletes the reserved stem cells continuously. So a fractionated total dose of 1.2 gray is found to be a threshold dose after which permanent testicular damage is possible. Also in total body radiation as conditioning for hematological stem cell transplantation is associated with a significant germ cell failure. Cranial irradiation may cause secondary gonadal failure, especially if given high doses of radiation to the brain. So for irradiation-induced damage to Leydig cells, Leydig cells are susceptible to damage, but the doses required are much higher than those needed to cause germ cell failure. And Leydig cell damage has been shown to be dose dependent and irreversibly related to the age at treatment. So essentially, a dose of 24 gray or more can lead to delayed sexual maturation in prepubertal or pubertal boys, and they may need androgen replacement therapy, whereas doses of less than 20 gray have not been shown to cause sexual maturation delay. So for recovery of human spermatogenesis after cancer therapy, a recovery of sperm production after cytotoxic insult is in an adult depends on the survival and the ability of the mitotically quiescent stem cell spermatogonia, that is the type A duct, to resume mitotic activity and to produce differentiating spermatogonia, that's the type A pill. And in the human testis, the exact mechanism of spermatogonal recovery has not been conclusively elucidated, but clearly depends on the dose and fractionation. So for risk of subfertility, according to diagnosis and the associated therapy, those at high risk of subfertility, diagnosis mainly leukemic testicular relapse, where you have testicular irradiation, hematopoietic stem cell condition with total body irradiation, you have testicular irradiation, preconditioning chemotherapy for hematopoietic stem cell transplantation, Hodgkin's disease and metastatic high-risk sarcoma, where you give high cumulative doses of alkylating agents. Those at low risk include the AML, standard risk ALL, Wilms tumor with no irradiation, sarcomas of stage 1, germ cell tumors with no irradiation, brain tumors where you have surgery only, or with cranial irradiation of less than 24 gray.
Summarize now.
Okay, so the current options for fertility preservation can be divided into three. First, non-gonadotoxic cancer therapy, but there have been improved cancer treatment protocols which have made progress in this direction. Although these protocols are under constant review, it is unlikely that treatment strategies can be improved without diminishing efficacy of the treatment. Secondly, gonadal protection. The first is using shields or removing the testis from the radiation field. Secondly, it has been tried through hormonal suppression, whereby this principle is based on disruption of gametogenesis, rendering the gonad less sensitive to the effect of cytotoxic drugs and irradiation. Unfortunately, it has been unsuccessful. Third is cryopreservation of gametes, which is the most reliable, routinely used option. And for pubertal boys with testicular volumes of 10 to 12 mils, they are encouraged to donate semen. And it's reasonable to obtain 2 to 3 ejaculates per patient because semen quality may be reduced. And it is strongly recommended that sperm be collected before initiation of cancer therapy because quality of sperm and DNA integrity may be compromised by cancer therapy. So if patients can produce sperms through masturbation, postpubertal through masturbation or peripubertal through masturbation, you sperm bank. If peripubertal and they cannot masturbate, you can do penile vibrio stimulation or electroejaculation. If the semen contains sperm, you sperm bank. If there's no sperm in the peripubertal and postpubertal, and they have achieved sperm mark, you can do a biopsy for sperm extraction and sperm bank. New for the future, you can do in vitro generation of spermatozoa from diploid precursors. You can also do germ cell transplantation and testicular grafting. Those are future.
Thank you.
Yeah.
second last presenter is Kagimbi Nyoro on urethral varicosities. Kagimbi Nyoro is a resident in the urology program, master's urology program at University of Nairobi. Dr. Nyoro, 10 minutes, stick to 10 minutes.
All right. All right, introduction has already been made. So I'll be presenting on urethral varicosities, a case series of 4 patients reviewed in one surgical unit. Urethral, so the bleeding pyrethra is a common urological symptom with many differential diagnoses. This is one of them that's overlooked, and also there is sparse literature on it, as well as very few case series, and much of the research done is on case reports. So this is one of the longest case series. We have 4 with annual of surgery in 2009 showing a case series of 3. It's a rare condition, rare but maybe underreported. And this one, and for these patients, we found that the urethral bleeding was caused by venous malformations in the posterior urethra, and all 4 male patients presented with post-coital, post-ejaculatory urethral bleeding, which was painless and associated with urgency. So the ages were 17 to 42 years, and their symptoms ranged from 2 weeks to 1 year. On physical examination, there was nothing to contribute to the diagnosis, and the routine hematological workup was normal. So what we did, we went ahead and did an invasive test, that is a diagnostics urethrooscopy, and that's because they fit the criteria for persistent post-ejaculatory hematuria or persistent hematuria, which is 2 months or more, or hematuria or pyrethral, not hematuria, pyrethral bleeding associated with 10 or more ejaculations. So here are the cases. So this is a 35-year-old with a 1-year history of post-ejaculatory bleeding. As you can see, I'll just give you, illustrate the extent, from very minimal varices to large varices. This one's easily missed. The size can be deceptive because, again, it depends on the intraurethral pressures and the irrigation rate. It's believed that the first photographs such as these are ours though, were first urethral varices were first photographed in 1997. So this is case 2, 22-year-old, 2-week history of pyrethral blood pyrethra after intercourse with left lung pain. Of course, they investigated for stone disease and found nothing. On urethrooscopy, there you are, you find the engorged veins, submucosal veins. Then case number 3, 17-year-old, again bleeding, this one with ejaculation and nocturnal emission. So he had a previous assessment 2 years ago, which yielded no results, and therefore, following the persistence of the symptom, he came back again, and you can see it would be hard to understand how someone would miss this, but from literature, it's a common occurrence where that this diagnosis is missed. So, and at this stage, it's actually at the transition zone between the urethral crest and the external urethral sphincter. Then case number 4 is a 42-year-old, 1-year history of postcoital bleeding with clots. This one was the first patient to give us photographic evidence of the severity of the hematuria. And the left one is a toilet with clots, surrounded by clots and hematuria. And then on examination, you can see that fungating engorged vein. And the distal, just in the far aspect, you can see the verumontanum. So these things are perimontanal. That's the area you mostly find them. I hope I'm audible. So we went ahead and treated these patients. And what we did a point electrocautery using rollerball. The other options you can have is using a loop or a Bagby. Again, you need to be careful about your margins and the depth of electrocautery because, again, you're just around the external sphincter. Literature talks about aiming for a depth of 2 millimeters. That you'll be left to your judgment whether you achieve that depth. Because again, you have to also worry that you don't get the most common complication is recurrence. On literature, you also read about people talking about electrocission, which means it's like a biopsy, and then cauterizing the bed of the varice. But that has been shown to cause a lot of post-op hemorrhage, and therefore we just recommend that you just cauterize. Historical treatments such as steroids and sclerosants have been outdated. So these patients were left catheterized for 72 hours, and the average follow-up was 3 months. There's no recurrence noted. So on the background, so this is these are benign tumors. They're irregular, thin-walled vascular channels lined by endothelium, and if not eradicated, they tend to recur. They are classified as either papillary or cavernous, depending. Capillary varices do not communicate. The channels inside do not communicate histologically. Cavernous, they communicate. So the incidence, most people talk about 40 years and less, sexually active individuals. Again, our subjects fit that epidemiological data. And from the causes of people presenting with hematospermia, you'll find in literature that it represents 4 to 7% of patients you'll encounter who it will be the underlying cause of hematospermia in patients who present to you. Again, 4 to 7%. So you see someone such as PAP found 8 cases out of 122, which is about, I think, 7%. So theories of its origin. So there is a residual angioblasts that do not progress to normal blood cells. There's existence of local varicosities. They say this urethra the submucous zone of the urethra in males is highly vascular. They talk about being more vascular than a normal or an enlarged prostate. And it has extensive arteriovenous anastomosis communications. And so another theory would be existence association with the syndromes of vascular syndromes such as Tujueba. There is high venous pressures, which can also occur during orgasm due to the generalized musculoskeletal activity, increasing intra-abdominal pressure and engorging veins in the pelvis. Then you have revascularization of a hematoma. Again, there are many theories, including chronic irritation. So we're presenting it because we think it's a disease that's overlooked, mainly because maybe it has a lack of awareness, and it can be misinterpreted as granulations, especially if you have high intraluminal pressures. In the video I played for you, maybe if you play it back later, you'll see like when you went back to cauterize, the varices at 6 o'clock had already collapsed. So just putting an instrument is easy to push out to cause efflux of the blood, and you can miss the lesion. And then, in supine position, which is where we do most of our endourology, it can make them apparently invisible. And so how you can improve this identification is by endoscopy immediately after ejaculation. They say ejaculation in theater, so find a way to incorporate that. or erection.
2 more minutes.
2 more minutes. All right. And then you wait for full bladder and urethral distension, reduce your flushing pressures as you're introducing your scope. And then adequate anesthesia, because a spastic perineum will compress the vessels against the scope, and therefore you'll miss the diagnosis. Those are my references. Thank you.
Thank you, Dr. Nyoro, for keeping time.
Yes, now we come to the last presentation of the day. That is Dr. Murage, who should be joining us by Zoom. I don't know if he is ready. I've been trying to contact him using my alternative means, but he has not replied. Is Dr. Murage around? Very well.
I'm around, yes.
Very good. So we'll go ahead and introduce Dr. Murage. Dr. Murage is a consultant obstetrician and gynecologist, and also a fertility specialist based in Nairobi. And he's one of my colleagues who I was in undergraduate with. He went back to school early before I did. That is why there's a very big gap between me and him, but we are all running our own races. So Dr. Murage, welcome to this session of CAUS. You have got the privilege of being the last presenter, so you'll have the latitude of having a few extra minutes, but you have 15 minutes as per our invited people. No, actually 10 minutes. 10 minutes.
Okay.
So
thank you, Dr. Misango, for the introduction. And I also want to thank the CAUS and Scientific Committee for inviting me to make this presentation. What I'm going to do is give you a brief about the ART status in Kenya, and then see where we can collaborate with yourselves in terms of improving outcomes. So I'll tell you about what's happening in Kenya presently. And because I know most of you are not involved in the assisted conception processes, then I'll give you a brief about that. And then finally we talk about urology collaborations with ourselves. So when we talk about assisted reproduction, we basically talk about IVF, which is in vitro fertilization, and ICSI, which is intracytoplasmic sperm injection. Basically, the sperms get injected into the eggs. But we should never forget these other less interventional treatments, which generally involve gender fertility advice. There's surgical and medical alternatives. And obviously there's things like timed intercourses and intrauterine inseminations, which I think would be familiar to most urologists. Now, the first question to ask is whether we have a needed population in Kenya. And this is data going back way 2011. But nothing tells us that things are any different. And this survey seemed to suggest that about 1 in 4 of every new gynecology consultations have something to do with infertility. So these are a huge population. And when we looked at the disease patterns, there's a predominance of what we call tubal factors. That basically means blocked fallopian tubes for the females. But for yourselves, if you look at severe or oligospermia, which was linked to azoospermia, the figure was quite high as well, about 14%. And when we looked at this in terms of demographics, we were able to work out that in every 1 year cycle, we might have about 2.4 million Kenyan couples requiring assisted conception in terms of IVF or even ICSI. So there's an ample need for this in Kenya. And then when you look at is ART available in Kenya, it's a sector that requires to be invested further in. There's actually no public sector involvement in assisted reproduction techniques. All the clinics which are in Kenya are private, mostly within Nairobi. We have a clinic in Mombasa and one in Eldoret. So you can see when you look at all the counties, there's quite a disparate spread of availability of ART in the country. Additionally, we don't have many skilled reproductive medicine specialists, nurses, and even our key lab personnel, we call them embryologists. They are quite lacking, and therefore we don't have huge skilled staff for adequate ART in the country. So there's a huge unmet need for ART overall in Kenya. In terms of what we do, obviously patients have to go through preliminary evaluations. We want to make sure they have a very clear diagnosis and make sure that IVF appears to be the most applicable treatment for them. Then we do something we call pre-treatment estimation of success rates. And the reason for this is IVF is quite expensive, and overall success rates are very poor. They rarely reach 50%. So we need to let couples know what kind of success they might expect. And this varies depending on age groups and their diagnosis. We have lots of treatment prediction tools that we use to estimate couples' success rates. And most want to know, do they have a 10% chance? Is it 40% before they can commit to treatment? And then once they're done, then they come for post-treatment debriefing. Those who get pregnant obviously go for antenatal care. So the females go through the brunt of IVF. The picture on your left-hand side of the screen is an ultrasound image of a woman going through stimulation and monitoring. So what you see as dark circles are actually follicles where eggs develop in. So they need serial ultrasound scans and biochemical monitoring for a period of about 12 to 14 days. Then on your right-hand side of the screen on top is egg retrieval.
Excuse me, Dr. Morage. Your screen is not sharing. Huh? Please share your screen we are not seeing your slides.
is already shared. Okay, could you check with IT whether there's something about it sharing, because I actually already shared it.
Share again.
Let's see.
Share again.
Okay, let me do. So, share screen. Is that visible now?
Not yet.
Not yet.
Not yet?
Not yet. Maybe as they try to work out on that, if there are any questions to the first presenters, somebody could, any questions that might be there on the floor, so that we save on time, huh?
This chance we give to Professor Mungai to ask his question. Can you pass over the mic, please, to Professor Mungai?
Misango.
Yes, sir.
Dr. Misango, I think your IT guys should enable sharing from my end, because it's shared on my end, but I think doesn't show because I don't have permissions to possibly.
They are trying to work on it. We have had a fairly seamless sharing with the other presenters from on Zoom. I don't know what's the challenge right now, but they're working on it, Dr. Just be patient, please.
So as we wait for Dr. Murage's slide to come on, my question was to Dr. Wahome. Counseling in patients with sexual dysfunction can be a difficult process, and I was just wondering what you do with patients who are being counseled about sexual dysfunction outside the family setup. The assumption is the treatment of erectile dysfunction or sexual dysfunction is that of somebody who is married and in a married situation. But there are people who come to us with relationship problems, sexual dysfunction, but their sexual function problems is outside the family married setup.
Thank you. Thank you for that question. Yes, it's true. You find out that the prognosis for those within marital setup, especially when you have to do the couple, works quite very well because there is consistency. But this person who is outside the family circles becomes quite very difficult. But what we have seen in some cases, usually even if they are outside, they maybe have a very regular partner and as the others. And so in that case, you are likely to work with them. But then, as we said, we also need to rule out whether there is other medical condition and also whether there is history of drug abuse, because sometimes most of them, one of the main contributing factors is alcohol and drug abuse. So if you can be able to do those other existing factors, you can be able to work. But generally, we can say that it works much better with those within the family setup. And number two, the EED problem, the dysfunction, is very rare among young people. So from the study we had, the list was 29 years, who was also taking a lot of alcohol and had multiple sexual partners. It was still difficult for him to go throughout the problem. It's an ongoing condition, but most of the others were within marital setup. So what I can say is that if you can rule out all the other contributing factors like alcohol and drug abuse, probably you can be able to achieve success. And among also those other partners, he may be having one who is regular, but it's much more better and easier with those who are within marital setup. Thank you.
Very well. I understand the technical problem has been sorted. So at the Q&A session, we will knock out Professor Mungai from asking any other question. We will have other people in the audience. So I think we can now go back to our online presenter, Dr. Murage. Please continue.
Okay, so I will carry on where we stopped. So I was saying when the females get stimulated and they reach the stage of egg retrieval, so we do that under ultrasound guidance and under sedation because it's very painful. And then the guys give the sperms on the same day. And then the next step is really to fertilize the eggs. On the top left-hand side of the screen is eggs within wells with sperms already within the same wells. for spontaneous fertilization, which would call IVF. So do that on patients where the sperms are just normal. And it doesn't matter the egg status, so long as the sperms are normal and fertilization rates tend to be appropriate. Then on the patients where there's severe oligospermia, or patients who require surgical sperm retrieval, then the only way to fertilize their eggs is by ICSI. And the picture on your right-hand side of the screen is an ICSI microscope, which has a joystick and magnification to be able to manipulate the sperms. So basically, the diagram on your left-hand side bottom of the screen shows a sperm being injected into a noocyte cytoplasm. So the sperm is just immobilized, held with a micropipette and injected within the egg cytoplasm. On your right-hand side at the bottom is actually an actual ICSI procedure being done with the sperm already being injected inside the egg. And then after that, then we'll just wait for fertilization, which is confirmed the next day. So about 18 hours later, on your left upper side of the screen is a noocyte which is already fertilized now with what we call 2 pronuclei. And the picture on the right-hand side, on the upper side, is a day 2 embryo, which already has 4 eggs developing. And then further down is an 8-cell embryo, which is day 3. And finally, at the lowest, the bottom right-hand side is what we call a blastocyst. This would be a day 5 embryo, which has the highest capacity to implant and, generally speaking, gives the best success rates after there's been embryo implantation. So once we know that we're going to do embryo transfer, then the patient will come on day 5 or day 3 after egg retrieval, and then we'll do that under ultrasound guidance and move the embryos into the upper cavity of the uterus. Finally, if there are spare embryos of good quality, then we would cryopreserve that for subsequent use, partly to avoid stimulating patients again and to avoid the cost of doing fresh treatment from zero. In terms of success rates, they're generally disappointing. The success rate will mirror the chance of conception naturally, and the younger the couples are, the better the chances of success. In a general setup, we would normally put success rates of about 30 to 40% at best. But as I said earlier, this would be dependent on patient factors, especially the female age. It appears men age do not influence success rate so much. And there's data that tells us, so long as men have sperms, the modification of fertilization and embryo development is 80% directed by the oocytes. And therefore, the modification for success rates would not mostly depend on the male age, even though we know that is contributory as well. We have attendant risks with IVF. One of the things we dread so much is something we call hyperstimulation syndrome. Basically what happens is patients respond too much to gonadotropins, injectable stimulation hormones, and then they produce too many eggs, and this can make them really unwell with ascites, very enlarged ovaries, and sometimes they might even need inpatient care to recover from that. It's usually self-resolving, but it's something that we try to avoid as much as possible. Then we have multiple pregnancy, which is normally guided by how many fertilized eggs we put in the uterus. Because of the risks associated with multiple pregnancy, then we normally would go for either a single embryo in good prognosis patients, or at most double embryo transfer to avoid mostly triplets and above. In terms of cost, the cost is about $5,000 to $6,000 per cycle in most clinics in Kenya. This translates into most couples, especially from the lower and middle income groups, not being able to afford IVF. And these are actually the most needed patients who have a lot of tubal disease and the like. National Health funding was covering IVF to a certain extent, but it's very selective and not very inclusive to most of the population. And unfortunately, private health insurance, especially local insurance companies, do not cover IVF treatments. Most people who have international covers like Bupa or Cigna would get somewhere between 3 to 6 cycles of IVF covered. So we have a role to play with our insurance companies and tell them to think about covering IVF if at all possible. Now, I think we can only do best for our patients if we have collaborations with urologists because of male factors. And we all know that when you work in multidisciplinary teams, outcomes tend to be better. So it's basic that most IVF units should have appointed urologists who they work with, who either are interested in fertility or they have experience. And this mainly helps guide very severe male factor problems with infertility. Equally, I think urologists who see a lot of male fertility patients should have a linkage with ourselves, partly because they rarely would see the female partners and they might have some information missing that may sometimes be important in terms of how the couples get treated. Generally speaking, general gynecologists have very poor male reproductive physiology knowledge, and having a urologist at the other end of the phone is very important for ourselves. We are lucky in our clinic. Dr. Burugu has been associated with ourselves for some years now, and we're able to get to him whenever we have something very severe in a male that we think we need urological help. And the obvious things that you guys can help us is severe oligospermia, patients with azoospermia, and patients who require urological surgery prior to fertility treatment. Because even though some of us can do testicular sperm retrievals, most gynecologists, even ones with fertility interests, will not be able to do all that. And having a urologist
you should be making your
conclusions is very helpful. So that's it. I'm happy to hear some inputs or questions from yourselves.
Thank you very much for your presentation, Dr. Murage. I will ask you to please remain online because there might be a few questions that the audience might have for you. So,
okay.
Dr. Otere, maybe you want to conduct this session?
Yes, indeed. Dr. Ihenya, quick one, precise and to the point. Maybe get another mic quickly.
Thank you, Dr. Alfred Murage, for that stimulating discussion. Mine is simple. Why is IVF expensive? And to Dr. Musau, we had a similar 25-year-old male who had undergone a dental cath from renal artery stenosis. And he saw the cardiologist put in, or the vascular surgeon put in a guide wire through his femoral artery. And when he went home, he took a wire, you know, like those electric wires we use for radio, and he put it into the urethra. Then he kept quiet for some 2-3 months. So they showed up in my office, and he volunteered that he had done something. We took him to theater, we scoped him, and we removed a foot of an electric wire. My question to you is, why didn't you consider scoping this patient before you did an open vesicle lithotomy?
Good question. I think we start with Dr. Murage, who is an external guest. Dr. Murage, do you hear me?
Yes, I think I can hear you.
Yes.
Part of the reason IVF is expensive is lack of competition, to be honest. We have very few clinics in Nairobi, in the country as a whole. There's no government as IVF services. So that is part of the problem. Number two, gonadotropins are very expensive. Patients spend somewhere between 150 to 200,000 bob to use the injections. And then finally, the IVF lab investments tend to be quite expensive. But there's no reason why we cannot look for ways of making IVF cheaper. And there's something we call minimal stimulation strategies that can bring down the cost by about half. So I think it's the way the market is playing at the moment, but there's room to make it more affordable.
Thank you for that response. Let's go to Dr. Musau.
Thank you, Dr. Wayenya. The key thing about this patient is that we had to go back after we found what we found to ascertain why. If you see the history, the way I've presented it, it is after we had gotten this extra information about his likelihood of having deviated into some paraphilia. But that is after we had already found that it was a cord and not stones. If you look at the ultrasound report, the smallest of the multiple stones that were given was 5.2. And so without this understanding of a likelihood of a different diagnosis, we had no reason to start scoping when you have the smallest of the stones being 5.2 centimeters. That's the reason why we didn't have to scope, because here we are, a bladder that is said to be full of stones, and scoping would not have made a difference from our clinical judgment.
I'll allow 2 short questions. I need to hand over this program. The organizers have been more than generous. 2 quick questions before we hand over the mic for this program to be closed.
Okay.
I can see someone at the back of the session. The hall,
okay.
I cannot see you properly. Dr. Sheikh? Who is
I'm asking a question, Dr. Mugalo.
Yes, Mugalo.
To Dr. Nyoro. At what point would you think of doing cystoscopy or ureteroscopy on these patients with maybe hemospermia or hematuria? Because there are many other causes.
Dr. Muigai, now my question is to Dr. Nyoro. Now, for these patients with urethral varicosities, what is the risk of urethral strictures post-op? And the next question is, how do you deal with, first of all, can you have a pan-urethral varicose? And how do you deal with that one?
Yes.
Dr. Nyoro, can we have your response quickly?
All right. So to the first question, invasive procedures are carried out, as you said, when you have a negative workup for any other causes of pyrethral bleeding or hematospermia. You've done your DRE, you've done your imaging, your prostate is okay. And then we talked about 2 months of symptoms or pyrethral bleeding associated with 10 episodes of ejaculation. There, now they say go ahead and do an invasive diagnostic test to check if you might be missing anything, especially if you're having a negative workup. Then for urethral strictures, there's no documentation of any urethral strictures post-electrocoarterization of urethral varices. Panurethral strictures, there's no literature on it. Anterior urethral varices are rare. They talk about mostly of that's a perimontanal urethral varices. No, so for anterior, they'll talk about maybe on the female side. That's why we talked about only men. But for females, yes, the anterior urethral strictures, which can present like a panurethral, because they can extrude all the way to the urethral meatus. And for those ones, again, the same modality of treatment. It's electrostition, electrocoarterization. Oh, yeah.
Thank you, Dr. Nyoro, for that response. And that marks the end of this session. It's been quite entertaining, educating, and informative. Let's give them a round of applause. And finally, it's now my singular honor and pleasure to hand over the program to the scientific committee through the secretary of the association. Thank you very much.
Thank you very much, delegates. Thank you very much, chairs of session. We now go to the closing ceremony of this function, which is going to be conducted by the chairman of the Kenya Association of Urological Surgeons, who also doubles up as the chairman of the conference and workshop organizing committee. Dr. Mburugu, welcome.
Thank you very much, Dr. Ecole. It is my pleasure to give the final remarks of this, which is, in my view, a very successful Cows Week. I'd like to thank you all for staying up to the end. I don't know how many of you remember the days we used to meet in Pan-Afric, when we'd start at 9, and by 12, the hall is empty. Kasim, you remember? Because guys have gone to do TRPs. That was part of the reason we decided to go out of town. So I'm really grateful that people were patient, even though we overran, even though sitting in this heat was quite an ordeal. By the way, here Nairobi was 34 and here was 31, so consider yourselves lucky. So even though it was an ordeal, you stuck to the end. So thank you very much, members and delegates, for that perseverance. So I'd like to thank the members of COWS for organizing yet another successful COWS Week. We talked about the camp, where we operated on 185 patients, and on those 185 patients, we did 220 procedures. Thank you very much for that selflessness. I also want to thank the delegates, the nursing staff from the various hospitals, who have become now part of COWS and who are a regular feature, and we hope to engage with you more and more, and we shall soon formally open a formal COWS nursing chapter. I'd also like to thank the members of my organizing committee. The organizing committee consists of the Vice Chairman of COWS, Dr. SNK Waweru, the Treasurer of COWS, Dr. Matu, the Secretary of COWS, Dr. Ecole, and Dr. Wambani, as well as Dr. Osawa. Thank you very much, gentlemen, for the hard work and late hours you have put into this. It is not a mean feat that you do, and it is not, we take it, we do not take it for granted. Thank you very much for all that you do for this Cows Week. We'd like to thank MMS, our secretariat, for being there for us in those late hours, even though out of that organizing committee, you do not have curfew passes. I don't know how you normally get home, but thank you very much for the good work you do. I'd also like to thank our hosts, Parkside Hotel, for being excellent hosts. You have fed us a lot of chapatis. I think all of us have gained a few kilos. The rooms, except for the mosquitoes, the rooms are good. They did not want us to carry swimming costumes, but I hear you can go skinny dipping at midnight. The water is still warm. So thank you very much, Parkside Hotel. Now, there's a long list of other collaborators and sponsors who probably we must thank. It's just good manners that we thank them. So bear with me. So we have the pharma industry, which includes GSK. This is an list in no particular order. So GSK, Getz Pharma, Harlis Limited, Sai Pharmaceuticals, AstraZeneca, Win Pharma, Janssen, Kusum Healthcare, Bard, Prota Limited, Crown Healthcare, Sun Pharma, Mega Importers, Pathologist Lancet, Surgilinks Limited, Menarini, Microlabs Limited, Asino Switzerland, Kenya, Pharma Bavaria International, MedServe Africa, Glenmark Pharmaceuticals, as well as the equipment providers and vendors who are Olympus Nairobi X-ray Services and also Crown Healthcare. Then the following institutions without which this Cows Week would not have been an actuality including East African Kidney Institute led by Professor Mungai here, Kenyatta National Hospital, University of Nairobi, Jordan Hospital, Kitui County Referral, Mwingi Sub-County, and Mutomo Mission Hospitals, Moi University and Moi Referral Teaching Hospital, Gertrude's Hospital, Mata Hospital, and MP Shah Hospital. We want to thank you sincerely from the bottom of our hearts. As you notice, the list of collaborating institutions is increasing by the year, and we are very grateful that you found time to be with us. And we hope we have treated you well, and we hope this encourages you to come back next year. And then I would like to thank the media team, the audiovisual team. I was talking to Professor Musibi and Dr. Njiraini in the morning. They have just held their Kesho hybrid meeting, which was a total fiasco, according to them. I'm using their words. It was a total fiasco in terms of audiovisual and online conferencing. So, guys, even though the shared, I think the only thing that we need to brush up on is the screen sharing thing. Otherwise, in my opinion, you have really tried. Thank you very much. And also this delay. I think, Dr. Ekol, have I missed out anybody? Have I missed out anybody? Hmm? Oh, yes, the anesthesia team, even though they are not here. I would really like to thank the anesthesia team who are drawn from various hospitals around Nairobi, both Kenyatta National Hospital, Nairobi, University of Nairobi, Mata, I don't know where Dr. Nyakundi is based, but Dr. Nyakundi from Mata Hospital, and various other doctors from various hospitals, as well as clinical officers and residents of anesthesia. We know that without them, we would not have had this camp. In the past, they accused us of abandoning them once we had used them, but we have gotten older and wiser, and now we normally give them, we normally arrange good arrangements for them so that they don't feel left out once we finish the camps. So we'd really like to thank them as well. We'd also finally like to thank Professor Rita Gobet, our perpetual friend of cows, who, because of COVID vaccine and travel issues, could not join us this year. Professor Rita Gobet has been a friend of cows, and especially pediatric cows, for many, many years. She has mentored people here. She has honed skills of people here. She has been our friend socially. She is a delight to be with socially. Now, Professor Rita Gobet, in her generosity, started an endowment prize of $500 to be presented to the best original presentation by a resident during the cows meeting. And there are various criteria, of which I can't remember them off it, but I think originality, blah, blah, and all that, relevance and all that. And so today, this year we had about 5 judges. There were 6, and then one had to rush away because of an urgent social issue. And these judges are the IEBC of cows, which was appointed by me, the despot, and which did not rig, have their results in. And so I am going to mention them. Do I mention them from the first or the last? I mean the last 5. I've mentioned the first 5. Do I mention them from 5 upwards or from 1 downwards? From 5 upwards. Okay. At number 5, we had Dr. Gohil. I think Dr. Gohil is a pediatric resident. At number 4, we had Dr. E. Kimani. At number 4. At number 3, we had Dr. Mustafa. At number 2, we had Dr. Yenya. And the winner of the Mula, the one who takes the Mula home, is Dr. Muigai. So I am privy to the fact that Professor Rita Gobet already sent the money to the cow's account. So Dr. Muigai, look for Dr. Matu, and if he refuses to hand over the money, I think you're more muscular than he is. So, and then I'll be at the bar upstairs once you have dealt with Dr. Matu. So, well done, Dr. Muigai. I think your paper on bladder cancer, redo TURBT, was actually deserving of that. Pediatric surgeons, was it rigging ama mwaka hii kulienda aje? Dr. Sawa, your team has let down the boss. Can you call them for a meeting? Okay, so next year, please, pediatric
you might
team.
want to know the anyway. I think it's better for the urology residents also to have a go at it this time around. But we promise them
Yes.
next year.
Next year kutakuwa kichapo.
We'll be back to the honors.
Kichapo. Kichapo. Okay. So without wasting much time, I'm sure you all want to go for the dinner and rest. Thank you very much. See you next year. From what I am hearing, next year might be Central Province. Central Province meaning Nyeri and its environs. But that is a decision not yet ratified. But just keep thinking about it. Thank you very much.
Thank you very much. You're all welcome to the gala dinner. It will be held in these garden grounds. When you're hungry.